So I think we should get started. Welcome to day 2. Hopefully you can succeed and live up to the reputation set by day 1. I'm Bleiweiss from the University of Pennsylvania. I'm with 2 moderators and my co-moderator, Fukunaga.
My name is Fukunaga. I'm working for the Communist Hospital, Salvador, Tokyo. Let's start. First case is presented by Professor Bleiweiss. He is international well-known breast pathologist.
So, I'm not going to be very fancy or molecular. That's just not my style. I'm kind of an old school H&E pathologist with a sideline of immuno. And so I'm giving away the diagnosis on the first case, and it's not such a big deal. But I want to make some points about what happens to the patient and how that particular diagnosis might be important going forward in the future. So the first case, as it says, is a small cell neuroendocrine carcinoma of the breast. And the clinical history is a 42-year-old female who was pregnant with twins. And she presented by complaining of a palpable right breast mass. And of course, her obstetrician, as would be, likely, thought that maybe the mass was related to pregnancy, but after it persisted for a month, he sent her for imaging, and she was already at 33 weeks. So at that point, a mammogram was done, and it showed a 4.2 by 3.0 centimeter spiculated mass with suspicious calcifications, and calcifications that are suspicious to a radiologist are linear and branching. So those of you who practice breast core biopsies know that those are the most suspicious because they could signify DCIS or comedocarbcinoma because the calcifications are following the tract of the duct system. In any event, that area of spiculated mass was consistent with the area of the palpable mass, and on ultrasound, it measured 3.6 by 2.2 by 2.9 centimeters, was solid and had irregular margins, and a core biopsy was done. So this is her mammogram, and that nice triangular marker is very handy for us non-radiologists because it's pointing out where the palpable mass was, but also where there's a spiculated density here, which I can't really see from here. But these are the linear branching calcifications that were so suspicious that were within that mass. Ultrasound, however, is much more obvious, I'd say, because you can see the markers are outlining the edges of this. And the edges of this lesion are very, very irregular. It's shaped in a very irregular way. It's taller than it is wide. And these are all ultrasound characteristics that are highly suspicious for carcinoma. So core biopsy showed an invasive carcinoma with 2 distinct histologic populations. One of which, and I'm going to show you each, was poorly differentiated and had partial micropapillary features, and by that I mean retraction spaces around individual nests of cells. And it turns out that that part of the micropapillary features, that feature is the most important because it's most likely to correlate with lymphatic invasion and positive lymph nodes. The second area, though, which partially mingled with the first, showed small cell carcinoma features. And interestingly, as I'll show you, both of them were positive for ERPR and negative for HER2. So even the small cell carcinoma was positive for estrogen receptor. And synaptophysin stain was positive only in the small cell carcinoma, not in the poorly differentiated duct carcinoma, the non-small cell type. So here we are on our core biopsy, And as you can see, there are nice retraction spaces around all these individual nests of cells. And that's the poorly differentiated duct carcinoma with the partial micropapillary features. But in other areas, you don't see those retraction spaces, and you just see nests of very blue cells, obviously infiltrating into the adipose tissue. And this caught the eye of the original pathologist, thinking that this looks very different from the other type of cells that were micropapillary in nature. Up on top you can see the retraction spaces again, but over here you don't see that, and again you have those nests of very solid blue cells without any gland formation, and some DCIS down below. So looking at these cells at higher power, you can see that these are not your typical breast cancer cells at all. There's very, very little cytoplasm to them. There's nuclear molding. The nuclei are sort of, I don't know if I would say salt and pepper, but they're kind of open nuclei. You don't really see nucleoli, but it's obviously high grade, and this was felt to be neuroendocrine, or small cell, I should say. In some areas, you can see them sort of spindle out. And again, these are just not your typical breast cancer cells at all. Here's a higher power of that area, and you can see these are very open nuclei. There's a high mitotic rate. There's necrosis accompanying with this. And so immuno, of course, was done on both components. And interestingly, both components are GATA3 positive. You can use that DCIS as a guide to where we are. And the non-micropapillary carcinoma as well, I'm sorry, the micropapillary type carcinoma as well as the small cell appearing carcinoma, they're both GATA3 positive. Here's ER, which is also positive in both components. So this is the non-micropapillary area, which, I'm sorry, the micropapillary area, which actually is less positive than the small cell area. Right, the small cell component is blazingly positive. And here's synaptophysin, which is quite positive in the small cell appearing carcinoma, and negative in the non-small cell appearing carcinoma. So the diagnosis was invasive poorly differentiated duct carcinoma, partially small cell neuroendocrine type. So what happened? So being that she was pregnant and fairly far along, they did not do a staging workup, which you would expect if somebody has a small cell carcinoma. And they didn't start any systemic therapy. So they induced the patient and delivered her at 35 weeks, and then went on to do a staging workup. And so an MRI was negative, a PET CT was negative for metastatic disease, and of course, most importantly, there was nothing found in the lung. And then she went on to get neoadjuvant chemotherapy combined with endocrine therapy, which is a bit controversial, and that's what I want to talk about a little bit. And the chemotherapy regimen that she got was one that would be directed at the small cell carcinoma component, cisplatin, etoposide, and then tamoxifen thrown in because she has an ER-positive breast cancer, trying to treat both aspects of the tumor. So after chemo was completed, her PET CT showed marked decreased FDG uptake, and that meaning in the breast, because there was nothing anywhere else. And 3 months, I don't know why they waited 3 months after chemotherapy to do surgery, but they did. So 3 months after chemotherapy, she had bilateral nipple-sparing mastectomy with sentinel node and reconstruction. And the residual invasive carcinoma, which there was, in the breast was all non-small cell carcinoma. Measuring 2.5 centimeters, she had one positive sentinel node out of 5, which was a 4 millimeter metastatic focus, and again, it was non-small cell carcinoma. And then she was treated with post-mastectomy chest wall radiation and went on to get more standard breast cancer chemotherapy, Taxol, Cytoxan, ×4, and then tamoxifen. So basically what happened here is that the neoadjuvant small cell carcinoma regimen seemed to have knocked out all the small cell carcinoma, leaving behind the more routine invasive poorly differentiated duct carcinoma. And here's her tumor post-neoadjuvant chemotherapy, which to my eye looks basically like any routine poorly differentiated duct carcinoma. Even parts of it looking like invasive lobular anamorphic type. And really very little, if any, chemotherapy effect with mitotic activity and no vacuolization of the cytoplasm and nuclei that we would expect after neoadjuvant chemotherapy showing a response. But definitely not looking at all like the small cell neuroendocrine type carcinoma that she had. So here we are in her mastectomy, small cell neuroendocrine carcinoma, treated neuroendocrine component. And so a few words to say about neuroendocrine differentiation in breast. This has been a sort of controversial topic in breast pathology for a very long time. And it turns out that neuroendocrine differentiation in breast cancer is really not so rare, but it's also not predictable. Because I like to tell my fellows and residents that if you look at any invasive breast cancer and you think that, oh, this looks like carcinoid, and you start staining it with neuroendocrine markers, half the time it'll be positive and half the time it'll be negative. And if you start taking any run-of-the-mill invasive duct carcinoma and you stain it and it doesn't look like neuroendocrine differentiation at all, half the time it will be positive and half the time it will be negative. So you really can't predict neuroendocrine differentiation in breast on the basis of the H&E. But does it really matter? Lots of studies in the past have been done looking at this, and it turns out that breast cancers that have neuroendocrine differentiation behave like breast cancers. Size for size, nodes, positivity, stage for stage, they behave like breast cancer. And if you start looking at breast cancers and doing immuno and calling everything neuroendocrine or not neuroendocrine, you're just going to generate a bunch of phone calls and a bunch of confused clinicians. So we basically don't do it. And so one other thing I have to mention is the WHO classification now, which is trying to unify the concept of neuroendocrine differentiation. The current WHO neuroendocrine tumor definition doesn't really apply to breast, because if you call it neuroendocrine tumor, again, you're going to generate all those phone calls, and it implies that there's benign behavior, but they don't behave benign, they behave like routine breast cancers. So I don't use any of that, and I don't stain neuroendocrine looking differentiation in breast because I like to avoid the phone calls. There's one exception, and the exception is small cell carcinoma. So when something looks like a small cell neuroendocrine carcinoma, you should stain it and prove it. Small cell neuroendocrine carcinoma is extremely rare, and as I've shown you in this case, it's usually mixed with other areas of routine run-of-the-mill breast cancer. Now, large cell neuroendocrine carcinoma, and these are differentiated in the WHO classification, is even rarer, and it's also mixed with other kinds of routine breast cancer. How do you diagnose it? Well, the histology looks the same as anywhere else. Hyperchromatic nuclei, nuclear molding, crush, minimal cytoplasm, mitoses, necrosis. But you must have at least one of these, a positive chromogranin and or synaptophysin. Obviously, you have to differentiate this coming from other sites. Now, it's very helpful, as in this case, that we have DCIS accompanying it. So that helps. And TTF being negative also helps. And interestingly, in all the cases I've seen of small cell neuroendocrine carcinoma of the breast, they're always ERPR positive and HER2 negative. Now, of course, we don't really know what small cell neuroendocrine carcinoma of the lung would be because we don't stain it for ERPR. So who knows? Of course, it's also helpful to do breast markers, as we did here. GATA3 was positive, and breast antigen and mammogram can be positive or negative. Large cell neuroendocrine carcinoma looks about the same, but it's just larger cells with more cytoplasm. So these are both rare entities. They're basically the thing of case reports. There's a wide age range, there's a wide size range. Most are actually node positive, and nobody knows how to treat them. And if you look in the literature, I know I'm out of time, but this is a long one, my other one's short. If you look in the literature, there's a very poor 5-year survival for these lesions, especially for large cell neuroendocrine carcinoma. There have been reports of using small cell regimens with variable success, but these are old case reports, and maybe modern chemotherapy is better. But most of these cases have been treated as non-neuroendocrine breast cancer, depending on the markers, ERPR, HER2, because they're mixed lesions. So here's another recent case that I just had, about a month or two ago. A 48-year-old with a BRCA2 mutation had a mastectomy with sentinel nodes, and she had 3 different tumors, one of which was a large cell neuroendocrine carcinoma, which was 2.5 centimeters, positive synaptophysin, INSM1 positive, GATA3 positive, ERPR positive, negative HER2, negative TTF, and a separate non-neuroendocrine invasive correlative diff, which was HER2 FISH positive, and a separate invasive lobular, which was ERPR positive, HER2 negative, all of them showing comedocarbcinoma, and what's in 2 of her lymph nodes, the neuroendocrine carcinoma. And so I can't tell you how this patient responded to treatment, but they gave her combined neuroendocrine and non-neuroendocrine treatment as our index patient. So here's her non-neuroendocrine tumor. Most of the picture is the ductal carcinoma. In the inset, you can see the invasive lobular carcinoma. And this is the mass of neuroendocrine carcinoma, just sheets and sheets of ugly-looking cells, more cytoplasm in the case that we had originally. And you can see this is just very different and very mitotic, even in ribbons and bands. And GATA3 positive, INSIM1 positive, synaptophysin positive, TTF1 CDX2 negative, totally different from the invasive lobular and invasive duct carcinoma. And what's in the lymph node looks identical to the neuroendocrine carcinoma. And finally, here's a liver biopsy that we received recently. A 48-year-old woman who had a prior non-neuroendocrine carcinoma of the breast, for which she got non-neuroendocrine carcinoma chemotherapy. And treated successfully, and a couple of years later, now has new liver and bone metastases. And you can see this is her liver biopsy, which shows metastatic neuroendocrine apparent carcinoma, normal liver here. And after this was diagnosed, she went on to a neuroendocrine chemotherapy regime, and her new PET scan after treatment is negative. So the neuroendocrine regime killed off everything in the liver and bone mets. So I suspect what happened in this case is that she probably had a small cell neuroendocrine carcinoma admixed with her invasive duct carcinoma originally, and was treated in reverse. They treated the non-neuroendocrine carcinoma, and now the small cell carcinoma comes back. And here's, again, the small cell carcinoma in the liver is ER positive, chromogranin positive, GATA3 positive, and even a few cells are positive for Malpica. Okay, so what happened to our patient? Well, she's about 4.5 years out from her primary treatment, no evidence of disease, and the twins are fine. So the moral of the story is, if it looks like small cell, stain it, because it may respond to modern neuroendocrine chemotherapy. So everybody's showing where they're from. This is the University of Pennsylvania, which was founded, I don't know how many years ago, by Ben Franklin. And there he is. There are lots of statues of Ben Franklin all over the place on campus. Here's one where I think he's reading the plans for the new hospital, which was being built when I got to Penn. And this was, I think in, I don't remember what year, but within a year, that's what it looks like. And it's a huge, huge building. Supposedly, they tell me that it's the biggest square footage building in all of Philadelphia. So.
Unfortunately, time is over. I'm afraid there's no time for discussion.
So I get to introduce Dr.
Good morning, old friends and new friends. I have two cases. These cases are easy to understand. I have no experience of genetic analysis, so you can relax to hear my cases. A 57-year-old G0 is a female who had been followed by another hospital for 4 years because of a uterine submucosal tumor. Was admitted in our hospital with rapidly enlarged uterine tumor. Tumor was clinically diagnosed as uterine sarcoma on CT and PET. Hysterectomy and bilateral salpingolectomy are performed. CT CT shows enlarged uterine is solid and cystic tumor. Macroscopically, tumor measuring 7 by 4 by 6 centimeter mass is growing into the uterine cavities. There are several well-demarcated nodules. These are leiomyoma. On cut surface, multiple yellowish-white lobular nodules with small cysts are observed in the uterine body and hummus, resembling Pilsen tumor of breast. Transmural invasion is noted. Histologically, surface has a very similar appearance of Pilsen tumor breast or leaf-like structures. Surface epithelium is covered by metaplastic squamous epithelium. There is no atypia. In the stroma, there are proliferation of spindle cells with myxoid stroma. There are many scattered dilated glands with periglandular stromal proliferation, periglandular cuffing. Stroma is fibrous and focally ossification, ionization. This is a very granular appearance. It's a very typical feature of this case. Some glands have the mild atypia. This tumor have two components. One is pinkish areas, less cellular areas, occupied approximately 60%, and remaining 40% is a very cellular element of blue areas. This is less cellular areas. Benign appearing spindle cell proliferated with fibroid structure. There is no mitotic figure or necrosis. This is more cellular areas of spindle cell. There is mildly atypical spindle cell proliferate in fascicular arrangement. There is some mitotic figures. This component seems to be borderline or low-grade malignant tumor features. Remaining 40% of this tumor is characterized by cellular, multilobulated cellular component. This shows a papillary projection into the systematic dilated spaces. It's a very cellular. Hyperview shows moderate atypical spindle cell proliferate in fasciculars and interlacing pattern. There are numerous mitotic activities. In some area has epithelioid appearance of a tumor cell. They show moderate atypia. And this area's stroma is very myxoid. Immunostaining of CD10 shows diffuse positivity in cellular areas. CD10 is positive with epithelioid component. Cyclin-1 is positive diffusely in cellular areas. Destiny is focally positive. Smooth mass rapching negative. ER is positive in low-grade area, but high-grade areas shows ER negativity. PGR is same. Grand and low-grade areas tumor cell is positive, but atypical high-grade areas negative for PGR. This is summary of immunohistochemical findings. High-grade component is positive for CD10, cyclin-1, B-mentioned. B57 shows wild type. Here 67 is positivity about 50%. Other marker is negative. And low-grade component, CD10, cyclin-1, B-mentioned, is positive some areas. And KI67 only 10%. And here PGR is positive only in low-grade component. Diagnosis is adenosarcoma with sarcomatous overgrowth, stage 1C. The tumor recurred in the retroperitoneum 30 months after surgery. She had been treated with chemotherapy. She's alive with disease. Comment: some adenosarcoma cases are associated with tamoxifen or prolonged estrogen use or radiation therapy for pelvic malignant tumors. overgrowth of more than 25% of tumor by pure heterogeneous high-grade sarcoma occurs in about 10% of cases. These tumors are called adenosarcoma with sarcomatous overgrowth. These tumors invade biometry more commonly and more deeply than typical low-grade adenosarcoma. Sarcomatous overgrowth is associated with recurrence, distance, metastasis, and death from tumor in 70%, 40%, and 60% of patients, respectively. Prognosis of typical adenosarcoma generally favorable compared with other gynecologic sarcoma. Sarcomatous overgrowth, deep biomaterial invasion, and extraordinary recurrence are adverse prognostic indicators. Differential diagnosis include adenofibroma, carcinosarcoma, and endometrial stromasarcoma. Adenofibroma is very rare in endometrium. It's like periglandular condensation, coughing, cellular atypia, high mitotic activity. Carcinosarcoma has high-grade carcinoma element. Carcinosarcoma, endometrial stromasarcoma do not show pleuris-red architectures. This tumor lack genomic aberration and specific chromosomal rearrangement found in other gynecologic sarcomas. This is a picture of Japanese monkey enjoying hot spring. It's mountain area, Death Valley in Japan. Thank you very much for your attention.
Any questions or comments for Fukunaga? Okay, I guess I'll introduce myself as the next speaker. So I promised this would be short, and it will be. From the title, you might expect me to be talking about a patient who had a liver transplant and then got breast cancer. Yes? Not exactly. So I'm going to ask you in this kind of case to start thinking outside the box, because that's what I was forced to do when I first saw this. So the patient was a 58-year-old woman who had cryptogenic cirrhosis and cholangitis and recurring biliary abscesses, and eventually, after lots of different treatments and attempts at treating her, received a liver transplant in 2022. I know nothing about transplant therapy. I do know that tacrolimus is an immunosuppressive agent, and I do know that transplant patients get immunosuppression. That's all I know. And she got prednisone. So looks like about a year after her liver transplant, she was admitted complaining of back pain, abdominal pain, and she had elevated liver function tests. An MRI of the abdomen at that point showed multiple masses throughout the liver. Remember, this is her liver transplant now. And interestingly, about 8 months before that, an MRI of her abdomen, which was, I guess, done in the routine course of following up with patients with liver transplants, showed a normal liver. So what happened in that 8 months? So we'll go back to the timeline again. So September 23 is when she's admitted with all the back pain and LFTs. And in September 23, she gets a liver transplant biopsy. And the biopsy, of course, first went to my GI and liver colleagues. One of whom was named Xiaohai, and he looked at it and thought, gee, this is metastatic carcinoma, and I think this looks like breast. And at that point, literally, very shortly thereafter, after he had looked at it, I was called by the head of breast imaging to please look at a liver biopsy. Why? And she told me that this diagnosis came out and there's just nothing in the woman's breast. They had done a mammography, they didn't do anything else, but the mammography was negative. And you know, you would expect that somebody who's presenting with metastatic breast cancer in the liver, it should be fairly obvious on a mammogram that there's something somewhere. You know, not necessary to do an ultrasound and MRI probably. And then literally moments later, this all happened in the space of about 10 minutes. By pure coincidence, the GI fellow brings the slides over to me. So I didn't have to go chasing anything. So this is part of her liver transplant biopsy, which shows a normal liver, no rejection. Not that I would know what that looks like. And this is probably what her liver looked like 8 months ago if her liver had been biopsied at the time there was a negative MRI. So let's switch to some other areas of this transplant liver biopsy. So this is 11 months after her transplant, and obviously there's metastatic carcinoma here, or metastatic something. And it's, you know, very high grade looking. You can see a little nest being formed up on top. There's areas of necrosis. And again, one of my favorite things is these retraction spaces around individual nests of cells. You might say, well, Bleiweiss, you're just making that up here, but we'll see. The other thing to note here is, despite maybe some overstaining, I think there's some apocrine features, at least to the cytoplasm here. Obviously, this is a very rapidly growing tumor. You know, with the necrosis, the first thing you do around areas of necrosis, that's where you look for mitosis, and there's certainly plenty of them here. Lots of nuclear polymorphism. Again, this sort of nesting appearance. And again, vaguely retraction spaces around some areas, maybe micropapillary appearance. So, immuno, of course, being done, CK7 positive, CK20 negative. Now, this is interesting. Breast antigen is quite positive. So breast antigen, for those of you who may or may not know, is a very, very specific marker, but it's not very sensitive. So the specificity of breast antigen, which is BRST2, or gross cystic disease fluid protein 15, took me many years to be able to say that fast, it was derived against apocrine metaplasia-lined cysts. So it's derived against apocrine differentiation, and the more apocrine a tumor looks, the more cells will be positive. And so if you see even 1 or 2 cells in a sea of breast cancer that are positive for this, it's very useful because it's a highly specific marker. It's 95% specific to breast origin, but it's not very sensitive, as opposed to GATA3, which is the opposite. So this is a tumor that's positive for breast antigen. It's all positive for GATA3. It's negative for ER/PR. It's negative for hemoglobin. It's negative for many, many other stains that my colleague in GI did. And it's positive for HER2. So this is a 3+ HER2 positive stain. I'm not going to talk about HER2 low, or ultra low, or very low, or kind of low, or lowish, or any of those things. So this is 3+. So if you've got a metastatic carcinoma that's HER2 positive, breast antigen positive, GATA3 positive, it's breast cancer. So, but there's nothing in her breast. And this is only in her transplant liver biopsy. Where did this come from? You know it's breast cancer. Now it's time to think outside the box. So, could it have come from the liver donor? I think it's possible. So we sent tissue to our molecular pathology colleagues to do identity testing. of different uses of identity testing, and I am not going to explain how they did it because it's way beyond my feeble brain. But let's talk a little bit about what the uses of identity testing are. The most obvious come to mind in forensics if you watch a lot of TV. The next most obvious thing is paternity and relationship testing. But then there are all kinds of other things. So bone marrow transplant chimerism, unidentified or mixed up sample resolution, foreign tissue fragments and surgical pathology, of course, floaters, molar pregnancy evaluation, maternal cell contamination in prenatal samples, graft versus host disease evaluation after transplants, and recipient versus donor origin of tumor after transplant, which is exactly the topic at hand. So how did this play out? Well, this complex chart, if I can try to figure it out, shows that in this case, the liver cells obviously are the donor genetic origin, and the blood cells that are contained in the liver are recipient genetic origin, and the DNA from the post-transplant tissue is going to have mixed recipient and donor DNA. But here's what was tested. So the native liver that had been explanted was still in our files. And so obviously that was the recipient DNA. We got a buccal swab from the patient and the DNA matched, luckily. Then we also had, along with the transplant liver at the time, we had the donor gallbladder. And the DNA of the donor gallbladder was the donor's DNA. The transplanted liver, the benign part of it, matched the donor with a mix of recipient DNA, meaning her RBCs, or blood, and the metastatic carcinoma had the DNA of the donor. So did the carcinoma come from the liver donor? The answer was yes. Alina's eyes are popping out. Yeah, that's exactly what happened to me too. I couldn't believe it. So a lot of questions came up in my mind about this case when we realized that. Was the rapid tumor growth over the 8-month period due to immunosuppression on the patient? Maybe, we'll never know. But then some other questions. Well, how carefully are donors really screened? And it turns out not that carefully. What about other organ recipients from the same donor? Well, we notified GOL as our local transplant coordinating organization, Gift of Life. And in the United States, these organizations are regional and they coordinate with each other. So I don't know where the other organs from this donor went. Lung, heart, and kidneys could have gone all over the place. But we notified the organization that we had done this and found this, and so far all the other recipients are okay. How to treat this patient? Well, she got chemotherapy, which is HER2-based chemotherapy, Herceptin, and pertuzumab as well as chemotherapy, and eventually she got a new transplant, a new liver. But after that, there's no follow-up, so I don't know what happened. But more importantly, what I was trying to figure out, well, how often does this happen? I mean, we get liver transplants, we're a transplant center, we do this all the time, and how frequently can this occur? Because it's kind of scary. So I went down this rabbit hole, looking at literature that I normally would not look at. And it turns out there are really only two very good review studies. One's old and one's recent. In 2004, this guy Buell created a registry. And but this registry was 296 transplants of patients, donors who had known the malignancies. I couldn't believe that there would be 200, almost 300 transplants done in patients who you knew had cancer. So I guess that has to do with the shortage of organ donors and the greater need for organs to be donated. It's obviously a risk-benefit ratio, but still. So 42% of these transmitted a tumor to the recipient, and the highest type of tumor that was transmitted was melanoma, and 58% of those patients were dead of disease. The second, another one was choriocarcinoma with a 93% transmission rate, and 74% of them were dead of disease. You could argue, well, they really needed the organ. What's better? Then in 2022, a more recent study, a literature review of 58 different publications. Now it's a rare event, 73 cases with the average time to diagnosis of 8 months. Liver transplants mostly, seeded, heart transplants 10, lung 10, multiple organs 2, but 75% mortality, median survival time 7 months. In 13 cases, patients were retransplanted, and 3 out of those 13 had recurrent cancer in the new transplant. And of those, 2 out of 3 died. What kind of tumors? In these cases, 6 of them, again, the tumors were found before the donor was assessed. In other words, they knew the patient had cancer, and they used the organ anyway. 23% after transplant. What kind of tumors? It's all over the map, but breast is way, way down on the list, and it's one of the other cases. But again, melanoma and choriocarcinoma are high on the list. So if you want to go down this rabbit hole, you can, and those are the 2 references. I can tell you that we do frozens on liver biopsies and kidney biopsies to assess adequacy for transplant, and occasionally the transplant surgeons will find something unexpected in the patient. And one night, always at night, I got a biopsy of an adrenal, which showed a pheochromocytoma. And guess what? They used the organs anyway. Anyway, that's all I have.
Thank you very much for this complete cases. Do you have any questions or comments?
Has anybody seen this? Good. So, our next speaker is Dr. Perez.
Good morning. We are going to the case 24, and I'm going to tell you how the story was. This is a 27-year-old woman with a pulmonary nodule that was treated with another hospital, and that was sent to the hospital. It's an oncologist hospital, so they sent us as a metastatic disease or something, and they sent us this slides. I don't have the gross picture because it was operated in another hospital, and you can see how the vision is well delimited. Okay. Like metastasis, you can see here, and it was only one nodule. It's all the disease that the patient had. In this picture, you can see that it's a lot of necrosis. You can see the mix between the inflammatory cells and the necrotic areas. But focally, you can find some residual cells, like in this area. Some nests that you can see here, Closer, you can see how the cells are polygonal, large cells with eosinophilic cytoplasma. The nuclei are large with evident nucleoli, and we cannot identify many mitosis. We identify a lot of necrosis, and we identified a lot of inflammatory tissue. This is another area with residual disease, and you can see how the cells are a few. There are not a lot of cells. And we saw this eosinophilic material that is not necrosis. The necrosis is in these areas. And you can see how the nests are with a lot of tissue with necrotic and this eosinophilic material. The lesion was positive for cytokeratin, was positive for P63, and P53 was not mutated. So we did more immunostains are P16 positive focal only. This is because in Mexico we have a lot of squamous cell carcinoma of the cervix. So we always have this differential diagnosis in mind. If something looks like a squamous cell, we always do this, and we have a very young patient. So after this, we didn't know nothing about the patient. If she has a previous history or something, we didn't know nothing. And we added some immunostains, and one SAL4 negative, gonadotrophin negative. Blood was focally positive, and HPL was negative. So we called to the other hospital and asked for a history. And the patient had a diagnosis or more 5 years before. This is the slide of the previous biopsy, and you can see how the bills are dilated. You can see here with some proliferation. Is not a very complete mold, but was the only antecedent of the patient. But the patient after this was follow-up, and during the follow-up the patient presents elevated HEC, but it's only 2000, and had this pulmonary nodule. After the diagnosis, the patient receives chemotherapy. They don't specify what kind of chemotherapy, but the marker never decreased. So the option was to resect the lesion because it was the only lesion. She, in the uterus, was completely normal. They don't have nothing in the uterus, and only have this nodule in the lung. So after the surgery and after the patient was sent to us, the patient is alive, she is good, and she had a follow-up for 2 years, and apparently she has not a recurrence today. So what is this? This is an intermediate trophoblastic lesion, and this is an epithelial trophoblastic tumor metastatic to the pulmon, to the lung. So if it's metastatic or is a second neoplasia or is another neoplasia, we are going to discuss that now. Only for remember, the intermediate trophoblastic have two kinds of cells. One is the implantation site cells, that is the origin of the placental site tumor, trophoblastic tumor, and the other one is the chorionic type, that is the origin of the epithelial trophoblastic tumors. And this is important because the immunostains are different of this. These tumors are very infrequently, and as you know, they are related with pregnancy or any kind of pregnancy. For that, are present in a young woman. But some cases have been reported in postmenopausal women with 60 or 65 years old and present many, many years after the pregnancy. The lesions when are primary of the uterus, presenting with transvaginal bleeding, persistent levels of the human chorionic gonadotropin, but these levels are not so high. That's very important, because when you are seeing that, your differential diagnosis is a choriocarcinoma. So if you have thousands, maybe it's a choriocarcinoma, and then the differential diagnosis is obviously a choriocarcinoma monotyping type. So we have to remember that they are associated with any kind of pregnancy. Can be a normal pregnancy, a molar, or another kind of trophoblastic lesion or no lesion. Many lesions are benign, but there are some that are metastases, and the sites of the metastasis is lung, liver, etc. But there are something very interesting, because if you have a previous molar pregnancy and you don't have an epithelioid trophoblastic tumor before, how do you explain that now you have an epithelioid trophoblastic tumor in the lung? That's the question. So apparently the molar have a metastasis to the lung, the molar tissue stay there, and after a while, if you remember how is all this trophoblastic tissue, for the molar in the lung start to growing a trophoblastic tumor. So it's very interesting. For me, it's very interesting because you can see how you have another lesion, and now you have a new lesion that is more apparently more. Is not a benign. Apparently, it's not a benign lesion. The diagnosis is very important because the choriocarcinoma is very sensitive to the chemotherapy, but the lesions are not. So if you're doing the wrong diagnosis, can be treated as a choriocarcinoma and she's never going to respond. There are prognosis factors for these tumors, like the FIGO stage, that is very important, the interval between the pregnancy and the diagnosis, and the levels of the beta-chorionic serum. Another, histologically, is the count of mitosis. And the differential diagnosis depends on the site of the lesion. If the site of the lesion is the uterus, the differential diagnosis are another trophoblastic lesions, and another epithelial lesions like a leiomyosarcoma or squamous cell carcinoma. So if it's not a uterus, that differential diagnosis is a metastatic disease. So if you have in the uterus, the main differential diagnosis is choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. You can see all the difference in this table, and the picture is of the placental site trophoblastic tumor. So you can see that they are very close. They looks very, very, very close. So how do you do the differential diagnosis? Well, the immunostains are very useful in these cases. P63 is very useful to do the differential diagnosis between epithelioid trophoblastic tumor and placental site trophoblastic tumor. Obviously, if you differential diagnosis, including choriocarcinoma, gonadotrophin is your choice. This table is very useful for me. I always have this table in my office, because I always forget what to do with these kind of ablations, because are very infrequently. So you can start with some keratins, after that P63 and lactogen, and if you want to divide for prognosis, you can use Ki67 or cyclin E. You must keep in mind that this kind of lesions are frequently located in the lower uterine segment. So when you are seeing some hysterectomy, you can always keep in mind that you can have this trophoblastic lesion. And how in this example, you can see here the cervical, and when you are closing, you are seeing a deep tissue with a lot of necrosis, and you can see what different poblations. You can see here better, and you have these syncytial areas and these multinucleated areas, and this is a choriocarcinoma. But if you remember how to say how to do the diagnosis of a squamous cell carcinoma, the cells can be. We can have many variants of the squamous cell carcinoma, and some of them are growing like a syncytius, and some of them can have giant cells multinucleated cells, and many of that cells are positive for the markers for serum, they are positive for all these markers for epithelioid trophoblastic disease. So that's important to keep in mind. So what we can do, if you remember, both lesions are positive for P63. They are positive for keratins, for any kind of keratins. But the group of the MD Anderson, they described the cytokeratin 5/6 as very useful for the differential between choriocarcinoma and squamous cell carcinoma in these areas. Another differential diagnosis that you can do is a very infrequently tumor, but you can see very pleomorphic neoplasias there. And always you have to keep in mind that you can see a melanomas in gynecological tract. So it's very important to do that. Sometimes are positive focally for keratins. Don't forget that melanoma can have many expression of many immunostains. So you can see the melanoma positive focally maybe for keratins, but always have to order some especially stains for to the diagnosis. And remember that if you have a pulmonary mass in a very young woman, always you have to think in these kind of lesions, because this is a very sad case, example, that was diagnosed like a squamous cell carcinoma in the lung. But when you are doing the immunostains are positive for cytokeratin, but are positive too for gonadotrophic chorionic. So always keep in mind, very young patient can be pregnant and can have these kind of lesions. So only very fast immunohistochemistry is useful, but you have to remember that these lesions can share the expression with, especially with squamous cell carcinoma. And if you have a young woman with something that looks like very epithelioid and like escamoid, you have to think about this trophoblastic lesion that can be metastatic or can be primary in the uterus. Thank you very much.
Thank you very much. Very beautiful case. Any questions, comments? Thank you very much. Go to next case. Next case is presented by Professor Malpica. She is working for the Texas MD Anderson Hospital. Let's start.
Good morning. First, I would like to thank Dr. Suster for keeping this meeting running. This is the 13th edition of this wonderful event, and I think it's not only an important event to discuss the science, but also it has a very important social and human component that I think we all enjoy. I would like to thank everybody here at Bioptická, because we have been so welcome, and it's really enjoyable to be in a place where you feel that you are welcome so much. And the new generation of David Suster and Michal, because they have done an outstanding job running the meeting. So the case that I would like to share with you is that of a 38-year-old woman who presented with a 1-month history of abdominal pain. Imaging studies show a right ovarian mass that was solid and cystic and that measured 9.3 centimeters. Her CA-125 was 309 units per milliliter. She had a history of endometriosis, polycystic ovarian disease, and ovarian hyperstimulation syndrome secondary to in vitro fertilization and the usage of Clomidine. Patient underwent a total abdominal hysterectomy with staging, and she was found to have fibrous stage 3 disease. After surgery, she received adjuvant therapy in the form of carboplatin and paclitaxel, and after a follow-up of 6 years, this patient is alive, no evidence of disease. So this is the tumor that you have available for review in the section that was posted. So essentially, we have a tumor that has a cystic, papillary, and some glandular spaces. The papillary structures are lined by polyhedral cells that essentially are arranged in a single row of cells lining the papillary structures. And some of these the structures, you can see that they are like a ring of tumor cells, and in the middle what you see is some sort of eosinophilic material. In some areas we can detect the presence of stroma, but in some other areas the papillary looking structures are in reality a ring of tumor cells. When we pay attention to the cytology, we can confirm that indeed the polygonal cells that we are dealing with show nuclear atypia, and the cytoplasm is either clear or light eosinophilic, and we get some scattered mitotic figures. From the immunohistochemical standpoint, these tumors were positive for cells were positive for PAX8. There was patch expression of napsin A, and P504S and HNF1 beta were diffusely positive. This tumor was negative for ER-PR. We pay attention to this neoplasm. We can see that in addition to the polyhedral cells, there were areas where the cytoplasm in reality contained mucin, and the cells change in shape from polyhedral to columnar. So these cells are intermingled with the dominant population of polyhedral cells with clear cytoplasm. It was also noticeable the presence of some inflammatory cells throughout the tumor. If we move towards the periphery of the neoplasm, we can appreciate that there was a cystic component that was lined by columnar cells with mucin, and those cells were intermingled with some polyhedral cells with clear cytoplasm, and if we move around, we will see this polygonal cells where the cytoplasm appear denser, so something like an indistinct type of cellular elements that we could not really say that they were mucinous or they were clear cells. They were almost like a squamoid in appearance. Then, in the section that, of the block that was sent in a very small area, we can appreciate that the tumor changed its appearance. Now we have a proliferation of glands that are back to back, and these glands have a novel shape, and they are lined by columnar cells with secretory appearance in the cytoplasm. These secretory vacuoles were predominantly located towards the apical portion of the tumor cells, and in some areas we could see that they were subnuclear. This component was napsin negative, was PAX8 positive, and it was ER-PR positive, which contrasted with the results that we obtained in the predominant portion of the tumor. The diagnosis for this case is an ovarian mixed carcinoma, which is mostly composed of a clear cell carcinoma with mucinous metaplasia and very focal endometrial carcinoma, grade 2 with respiratory changes and focal mucinous metaplasia. The background was a mixed epithelial cyst adenoma, and in an area that was not available in the section that was posted, there was a focus of endometriosis. The mismatch repair by IHC, the panel was intact, and the tumor was microsatellite stable. So I'm taking advantage of this presentation to discuss some relevant points when it comes to clear cell carcinoma of the ovary, since we get these cases once in a while in our consultation service, because the histological appearance or the immunohistochemical profile are not in keeping with what we expect to see in an ovarian clear cell carcinoma. So from the beginning, we accept the fact that clear cell carcinoma is a tumor where we would like to see variable histological patterns. The architecture changes from areas where we have a papillary architecture, and these areas are going to be lined by a single layer of polyhedral cells. We like to see that those papillary areas alternated with the tubular cystic component, and keep in mind that whenever we have the tubular cystic component, the cells lining the cystic spaces can become quite flattened, and sometimes you really have to go to a higher magnification to be able to see the nuclear epithelium. In addition, we can see tumors where we see the distinct solid pattern. So we take as a dogma that whenever we are dealing with a clear cell carcinoma, we would like to see variations in the architecture. And these are the typical patterns that we're looking for: papillary, tubulocystic, and solid. However, sometimes these tumors give us surprises, and we are going to start with the first thing that we have to keep in mind. Some cases are going to show predominantly an eosinophilic appearance. You are not going to have the help of the clear cell. The second thing that you have to keep in mind, that a feature that typical of clear cell carcinoma in the GYN tract is that you are going to see discordance between the degree of cytologic atypia and the number of mitotic figures. So you see a distinct degree of atypia, and your mitotic index does not match that degree of atypia. So let's say that if we had a high-grade serous carcinoma, the tumor characterized by marked cytologic atypia, you will expect to find a mitotic index over 12 mitosis per 10 high-power fields. And that doesn't apply to clear cell carcinoma, where the mitotic index, even though that you have marked atypia, usually is lower than 10 mitosis per 10 high-power fields. Things that can represent confounding factors: the presence of mucin. In the case that I show you, we have the cells containing mucin. We can identify distinct portion of the epithelium showing the columnar cells with mucin. Sometimes, really, at low magnification, we see this distinct content, mucinous contents within the luminal spaces. And this can represent a confounding factor, especially when you are dealing with a core biopsy of a pelvic mass. Sometimes you're going to see targetoid cells that are really dominating the histological appearance of the tumor. Here we have one of these examples with the targetoid cells, where the most important cellular element in this tumor, you can see that these cells are diffusely positive for PAX8, and we have a patch expression of napsin A. Squamous differentiation in clear cell carcinoma is infrequent, but it can be seen. And here we have two examples of clear cell carcinomas where distinctive squamous differentiation is finding that we tend to associate with endometrial carcinoma was present. So we have the clear cell carcinoma, and then we have portions of the tumor lined by squamous epithelium. This is another example that was sent as a consult because pathologists who reviewed the case initially was not familiar with this squamous differentiation in clear cell carcinoma. The type of papilla that is very rare in cases of clear cell carcinoma of the ovary is the type of papilla that we associate with transitional cell carcinoma. As the example seen here, we have broad-based papillary structures, and if we look at the epithelium lining, this broad-based papilla, we see that the top of this thickened epithelium is smooth, and when we look at the portion, the inner portion of this lining, we can see the punch-out spaces. This is a type of papilla that is usually seen in high-grade serous carcinoma. It can be seen in endometrial carcinoma and rarely also seen in clear cell carcinoma. This case shows the expression of B504 and it was negative for WT1. Sometimes the distinction of clear cell carcinoma from serous carcinoma can be problematic, and this is an example of high-grade serous carcinoma where the tumor truly mimics a clear cell carcinoma. As you can see here, there is a diffuse expression of WT1, which takes the case from the clear cell carcinoma histotype. Clear cell carcinoma with sarcomatoid features shouldn't be mistaken for carcinosarcoma. So this was a case that was sent as a consult because there was a divided opinion regarding what was the name for this tumor. So we can see in this image the spindle cell component, and that spindle cell component is merging with the cystic component that we see here. There was diffuse expression of keratin, PAX8 was diffusely positive, HNF1 beta was diffusely positive in the spindle cell component. So clear cell carcinoma with sarcomatoid features. We always talk about the immunoprofile of clear cell carcinoma. Remember, the immunoprofile of clear cell carcinoma and the female genital tract is not a perfect type of situation. We talk about the expression of NAPSIN-A, P504S, HNF1 beta, and the lack of expression of ERPR, and P53 having a tendency to be wild type. However, you have to keep in mind that of the three markers that I mentioned, the ones shown on the top of this panel, the most reliable will be HNF1 beta when it comes to expression. But HNF1 beta can be expressed in endometrial carcinoma as well as in serous carcinoma. The expression of NAPSIN-A and P504 is problematic. Sometimes we see cases that are typical clear cell carcinoma. The expression is not as perfect as we would like to see it. It's either patchy or focal, not the diffuse expression that most of the articles in the literature mention. We keep in mind that about 12% of cases of clear cell carcinoma are going to be positive for ERPR, and P53 is going to be aberrant roughly in a similar number of cases. The loss of one of the MMRs is going to be seen in 6 to 13% of the cases. And keep in mind that we have to be mindful of the yolk sac differentiation that can be associated to clear cell carcinoma. So we're talking about yolk sac carcinoma that is somatically derived. So an example of this situation is shown in these two panels. This is clear cell carcinoma, and we have a diffuse expression of PAX8, diffuse expression of cytokeratin 7, with a patch expression of NAPSIN-A and lack of expression of SAL4. This other area of the tumor, which contains the yolk sac tumor, was positive for SAL4, negative for keratin 7 and PAX8, for NAPSIN-A also, and there was expression of CDX2, Klubickova, and alpha-fetoprotein. From the molecular standpoint, if we wanted to apply the molecular classes that have been described initially in endometrial cancer, most of the cases of clear cell carcinoma fall into a specific molecular profile, followed by the P53 aberrant group, followed by the MMR deficient, and polymutated represent the last group of cases. The most common mutations in clear cell carcinoma of the ovary are ARID1A in 51% of the cases, followed by PIK3 kinase, third promoter, KRAS, and less frequently, P53, ATM, P10, and POLE. And just a few words about the ovarian hyperstimulation syndrome, because I didn't know about this until this case presentation was being prepared. Essentially, this happens when you are doing the preparation for the in vitro fertilization. So in the past, they were using HCG to produce the retrieval of the oocytes, but when they were doing this, the luteinized granulosa cells were also producing the EGF, which was increasing the vascular permeability, creating fluid accumulation in peritoneal cavities and lung alterations in coagulation. Now, this is no longer a problem because they are using gonadotrophin releasing hormone agonists to trigger the oocyte retrieval, and also they are freezing the embryos rather than implanting the embryos fresh, because in that way they don't have a surge of HCG with a consequent elevation of lutein FNH. And with this image of North Texas, I would like to thank all of you for your attention to this presentation. The North of Texas ridge in cattle, and you can see that there is a strong respect for the quarter horse, the quintessential American horse. You can see that on the picture. It's a mural in Amarillo, Texas. For those of you that like architecture, is the picture in the middle. It's the Robert Brunner Steel House, which is an architectural icon in modern architecture. That's in Lubbock, Texas. And then what really sustained the part of the economy, that part of the country, is still agriculture. So you have a grain elevator. Thank you very much.
Thank you, Anise. I think we'll skip, you got a question?
Thank you. For this mixed ovarian carcinoma, which component was invasive one?
Well, the clear cell carcinoma was the predominant component of the two, and that's invasive. Okay. There was a little amount of what it looked intracystic. There was the endometrioid, but that has also a small portion of it, exactly, and it had some solid components, so it was a grade 2.
Okay, thanks. And our final presentation for the morning before the break is Dr. Fukunaga again.
Yes. 29-year-old Giselle female was admitted because of lower abdominal distension and abnormal vaginal bleeding. Her past history was uneventful. Image analysis indicate uterine myoma. A laparoscopic simple hysterectomy was performed. Macroscopically, there is an intramural membranous yellowish nodule measuring 5.7 by 5.0 centimeters. It's a well demarcated tumor. Histologically, it characterized tubular structures and stromal hyalinization. Hyperview. Tumor cells arranged in tubular and glandular structures. Tumor cell has ovoid or elongated nuclei. Some tumor cell has there is cohibin-like nuclear groups. Atopia is mild. There is no mitotic activities. A hyperview, some area showed cord-like structures. This tumor has scant cytoplasms. There is no cellular atopia. And this picture showed epithelial arrangement of a tumor cell. It could be adenocarcinoma. In this field, there is two components. One is tumor cell is clear cytoplasm. The other is spindle cell proliferate in epithelial patterns. Cytoplasm is very scanty. And half of right slide, they show epithelial arrangement of spindle cells. And vascular arrangement spindle cell with eutrophic cytoplasm. It looks like smooth muscle tumor. This also epithelial arrangement tumor cell. It could be smooth muscle tumor. This case showed vascular invasion. A summary of histology, well-demarcated margins, tubular and granular proliferation, cord-like arrangement in hyalinized stroma, vascular proliferation of spindle cell. There is mild atypia, vascular invasion, no endometrial stromal sarcoma element. This is very important histology. Immunohistochemically, tumor is positive for calretinin. D240. Inhibiting alpha is negative. This tumor is diffusely positive for D240, locally positive for WT1, CD10, calretinin, desmon, H-cardesmon, alpha-smooth muscle actin, and HAP45. Negative for A1, A3, calcium stem inhibiting, thioglobin, TTF1, HF35, melan N. Less than 1% of tumor cells were positive for K167. Diagnosis is uterine tumor resembling ovarian cell coat tumor. Patient is alive without evidence of disease 4 years after surgery. This tumor, by definition, non-conventional endometrial stromal component can be present. Presence of smooth mask-like element, a prominent called holotubulous, trabecular, and form cells. Sex cord element may be positive for keratin, desmin, inhibin, and other sex cord markers are polyphenotypic immunohistochemical profile. Uterine lesion with sex cord-like architecture include uterine tumor resembling ovarian sex cord tumor, endometrial stomach tumor, adenomyosis, endometrial polyp, leiomyoma or leiomyosarcoma, certain endometrial carcinoma, coded and hyalinized endometrial carcinoma, symmetric-like adenocarcinoma, and adenosarcoma. We should differentiate this tumor from endometrial tumor, smooth muscle tumor, or certiform or coded hyalinized endometrial carcinoma. Up to 23.5% of had intrauterine recurrence, having low-grade malignant potential. Hysterectomy with or without bilateral pharyngolectomy is considered standard treatment. Fusion involving growth regulation by estrogen in breast cancer 1, GREB1, and estrogen receptor 1, ESR1 genes have recently been detected in this type of tumor. ESR rearranged uterine tumor resembling ovarian sex tumor. Menopausal women, polypoid submucosal masses composed predominantly the predominantly of the unequivocal sex code element expressed multiple sex code markers. GRE will be arranged one. All the patient intramural masses, larger tumor cells, more mitotically active, variable and often inconspicuous cell photo-like differentiation, a more aggressive clinical cause than ER-SR rearrangement. Thank you very much for your attention.
Any questions, comments? Okay, so thank you, and I thank all of the speakers for this morning. And we'll reconvene. We're actually close to on time, amazingly. No thanks to me. But I guess we'll reconvene in about 20 minutes.
Everybody, next case is presented by Professor Malpica. It's a very interesting ovarian case.
So welcome back. So the case that we're going to discuss now is that of a 55-year-old woman who presented with a 3-week history of pelvic pain. She was status post hysterectomy for adenomyosis and status post appendectomy. Imaging studies show bilateral ovarian cystic masses with septation. The right ovary measured 16 centimeters while the left measured 10 centimeters. Her CA-125 was normal, 27.6 units per milliliter, and she underwent a bilateral salpingo-forectomy. The right ovary measured 18 centimeters at the surgical bench, while the left ovary measured 10 centimeters. The disease was staged as stage 1A. There was an interpretive assessment that had been done and it had been called in a certain way. The surgeon opted not to do any biopsies or mental sampling. He just went with the visual inspection of the abdomen and peritoneum and thought that there was no tissue that he needed to sample. The patient is alive with no evidence of disease 5 years after diagnosis. So this is the image of the tumor that was available for your review. Essentially, we have a neoplasm that had an important component, it was fibromatous, and then we have cystic spaces that were aligned by columnar cells that show the distinct amount of mucin towards the apical portion, and the nuclei are pre-uniform and located towards the basal portion of the lining epithelium. Again, another image to show you the characteristics of this epithelium, and very focal areas show nuclear stratification. Again, some foci that were rather small show nuclear stratification, seen here. More of the nuclear stratification that was seen focally in this tumor. No nuclear polymorphism, no conspicuous mitotic activity, just nuclear stratification. As seen here, the tumor was tested. Immunohistochemical studies showed that the tumor was positive for PAX8. There was diffuse expression of cytokeratin 7 and a patch expression of cytokeratin 20. DPC4 was obtained in P16 stained rare cells. Remember, this tumor was bilateral, okay? So, in certain areas of the tumor, you have this dramatic change from what essentially was an epithelium that was columnar with well-behaved nuclei towards the basal portion of the tumor cells, and you move along, you start seeing the stratification, You move along, and all of a sudden you land in this area where there is this distinct nuclear pleomorphism, disorganization, the chromatin distribution is irregular, there are numerous apoptotic bodies and numerous mitotic figures. These are other areas of the tumor where we can appreciate these glandular elements that display this very atypical epithelium similar to the one that I described a few seconds ago. And this is another area where we see the cyst showing these papillary structures, but what is noticeable is the marked atypia seen in the lining epithelium. Essentially, we have an epithelium that has marked atypia, conspicuous mitotic activity, and numerous apoptotic bodies. So the diagnosis is for the right ovary, foci of intraepithelial mucinous carcinoma in a background of a mucinous borderline tumor and mucinous histoadenoma. The left ovary, this slide was not available for your review, show a mucinous borderline tumor in the background of a mucinous histoadenoma. So we're going to review quickly some important information about mucinous tumors of the ovary. Specifically, when we deal with a case that's showing features like the ones seen in this particular example where we have intraepithelial carcinoma. So we have to keep in mind that mucinous tumors, primarily the ovary, tend to be large neoplasms and they're going to be heterogeneous, so sampling is critical. And the same tumor can contain benign areas, histoadenoma areas, as we saw here. We can see areas of borderline which happen to be quite focal in this example, areas of intraepithelial carcinoma, areas of invasive carcinoma, either expansile and or infiltrative. Everything together sitting in a large tumor. So putting a good number of sections will help. You have to keep in mind that the issue with mucinous neoplasms and other organs is solved with a simple approach. You put the entire tumor for microscopic examination. If you're in the appendix, if you're in the pancreas, you just put the entire tumor. In the ovary, we cannot do that because the tumors are rather large and that will essentially paralyze the lab. So we have a protocol that was an agreement that we had at a meeting in Bethesda many years ago. This protocol is not evidence-based, and we will never have an evidence-based protocol because nobody's going to invest the money that is required to know exactly how many sections we should be putting through on a mucinous tumor primary in the ovary. So essentially the protocol calls for the following. If we're dealing with a tumor that is smaller than 10 centimeters, you submit 1 section per centimeter of the tumor. If the tumor reaches 10 centimeters, you have to double your sampling. That means that you have to put 2 sections per centimeter, considering the largest dimension of the neoplasm. Tumors of any size with intraepithelial carcinoma or microinvasion, you have to follow this aggressive sampling rule, 2 sections per centimeter of tumor. Regarding mucinous borderline neoplasm, please pay attention to the fact that mucinous borderline tumors are usually unilateral tumors. This example happened to fall in that minority of cases that represent only 6% of the mucinous tumors that in the category borderline arising in the ovary, where you have bilateral neoplasms. So this is uncommon. These tumors, as this example shows, tend to be large, with a diameter that has been reported to be the average diameter in one study, 17 centimeter, another study, 20 centimeters. These are large tumors. Most cases are multilocular, and these cases of mucinous borderline tumor are always confined to the ovary. It's a stage 1 disease, okay? From the immunohistochemical standpoint, we know that mucinous tumors borderlines of the ovary are going to stain as shown in this cartoon. We have expression of cytokeratin 7, we have expression of cytokeratin 20, and about 86% 7% of the cases, but it's always to a lesser extent than what we see with cytokeratin 7. CDX2 is going to be positive in almost half of the cases, and PAX8 is positive in up to 60% of the cases. And a good rule to follow is when you're looking for your PAX8 expression in the mucinous tumor, primary in the ovary, tend to go to the benign portion of the tumor, to the cystinotic portion, because that's the area that is going to be showing for sure the PAX8 expression. Negative stains include ER/PR by Menti, WT1, and SALB2, and Delia, who is here, had a very good article regarding this specific topic, the expression of SALB2 in ovarian mucinous tumors. Something to keep in mind is that there is always the rare case that is going to express SALB2. And what can you do in those circumstances? If the patient is young, you can follow this rule. Just go to the cortex that is adjacent, a little farther away from where the tumor is, because in young patients, you're going to see changes in that portion of the ovary, where a young patient, and this trick is valid only for patients who are premenopausal. This doesn't apply to patients who are peri or postmenopausal, because what we're looking for in that cortex that is farther away from the mucinous tumor are changes that indicate that this is an abnormal ovary. And what is the abnormality that you are dealing with? Essentially, you are seeing a fibrotic cortex, so you have the mucinous borderline, and then you move away from the tumor, and this is the ovarian cortex of a patient who is 35 years old. So you notice that is fibrotic. Sometimes that fibrotic cortex becomes kind of loose, and you see a drop in the number of oocytes and follicles. So you're looking for that thick cortex in patients who are premenopausal. So if you have problem with your immunos, go to that cortex a little farther away from the tumor and try to see if you see fibrosis, if you see a loose fibrotic background, if you see a drop in the number of oocytes and follicles, because that will indicate that this is an abnormal ovary where this mucinous tumor arose, okay? That rule applies only to cases that are detected in patients who are young. Regarding intraepithelial mucinous carcinoma, the use of P53 and P16 is not totally reliable because you can see P53 wild type, you can see P53 aberrant, and the same can happen in cases of borderline. So you have to follow the rule. To call it intraepithelial carcinoma, you have to be looking at tumors that are showing that lining epithelium with marked atypia in the form of nuclear polymorphism, irregular distribution of the chromatin, mitotic activity that is conspicuous in numerous apoptotic bodies. The critical question that clinicians always ask us, what is the recurrence rate? And this is a number that you have to know because they don't know. Because this is information that has to be presented to the patient because we don't have treatment for intraepithelial mucinous carcinoma. These patients are just followed, okay? But patients want to know what is the risk of recurrence. So the number that has been quoted by most people is the number that comes from a study that was conducted at Mass General, and the number is 5.8%, okay? For 5-stage 1 disease. However, if you want to go for more granularity in your information, you have to refer to a study by Thai investigators where they give you a better idea about how this recurrence rate plays according to the capsule involvement or absence of capsule involvement. So for a stage 1C disease, the recurrence rate is 11.1%. If the capsule is intact, you have a recurrence rate of 2.9%, okay? So another point that you have to remember is that intraepithelial mucinous carcinoma is a focal or patchy problem. If you have diffuse disease, you have to contemplate the possibility of metastatic tumor to the ovary. And I will show you some examples that we have received in our consultation service where the question was, is this an intraepithelial mucinous carcinoma. And this is example number 1. This was a tumor where the entire neoplasm was a cystic tumor with papillary areas that look like kind of crazy. They show this medusa head appearance, and indeed, the neoplastic cells contain mucin. Look at the marked nuclear pleomorphism, but this was seen in every single section of the tumor. So if you follow the rule, intraepithelial mucinous carcinoma cannot be a diffuse process, immediately you have to consider possibility of metastasis, and the most frequent culprit is cervical adenocarcinoma that has not been diagnosed, okay, at the time of the pelvic mass identification. This is another example of cervical adenocarcinoma that was sent as a consult, because the question was, is this a diffuse intraepithelial carcinoma mucinous type? No, this was metastatic cervical adenocarcinoma, and this is another example of metastatic cervical adenocarcinoma, HPV associated, where the disease mimic an intraepithelial mucinous carcinoma. With this image of Houston, Texas, I would like to thank you for your attention to this presentation. If you have any questions.
Any questions? Okay, thanks. Our next speaker is a new member of the faculty, Dr. Ramalingam.
Good morning, everybody. My name is Ramalingam. I'm faculty member at MD Anderson Cancer Center, and I work with Dr. Malpica. I have to thank her for letting me join the AMR group and family, and I'm very happy to her and thankful to her and also Dr. Suster for this opportunity. The first case that I'm going to present is that of a 38-year-old female. She presented to her gynecologist with abdominal pain. A pelvic MRI showed a left ovarian hemorrhagic cyst, and she underwent a unilateral salpingo-oophorectomy. So this is a low part view of her ovarian tumor, and you can see that the entire ovary is essentially replaced by this high-grade malignant neoplasm, and even from this power you can see that the tumor is very solid, forming basaloid nest with geographic necrosis that's present pretty much everywhere. Please note that there's really no normal ovarian tissue that's left behind. A closer examination shows basaloid nests that are of varying sizes, kind of infiltrating the stroma, irregular nest, and also the presence of these areas of geographic necrosis. And from this part, you can also notice that there are some areas which look a little pinker, and we're going to take a closer look. So if you zoom in on those areas, you can see that there are areas of abrupt keratinization that are present over here. But the remainder of the tumor that's present over here looks pretty basaloid. The nuclei are quite atypical, but they're relatively uniform without obvious pleomorphism, but still pretty high grade and atypical looking. Another thing to pay attention to is the presence of these trichohyalin granules that are frequently identified in this tumor. I want to talk a little bit about the necrosis. If you pay attention to the necrosis, it almost looks like the coagulative necrosis that you would see, like say in a Bleiweiss sarcoma, or comedo-necrosis as you may see in the breast. But the transition between the basaloid tumor cells and the necrosis is quite abrupt. And this is how the necrosis looked in the majority of the tumor. And that's important. So upon much, after much searching, you can find that in some areas you have a slightly different appearance. Here you have this kind of lamellated keratin forming ghost cell keratinization and shadow cells, as they call it. But this finding was very focal, and you really had to look at the slide carefully to find these areas. And this focal finding is important, but also to remember that sometimes you really have to look at multiple sections before you identify this histologic hallmark of this tumor. From an immunohistochemical standpoint, the tumor was diffusely positive for cytokeratin 5-6 as well as CK7, but please note that PAX8 was negative in the tumor cells. Synaptophysin and CDX2 were both patchy positive within the tumor cells, and sometimes a synaptophysin can be quite diffuse in some cases, which can cause trouble with the differential. But they're also positive for CDX2, and so you can imagine that in a metastatic site, this can be confused for a tumor of GI origin. P53, as you can note over here, was wild type. Another very important finding was the presence of diffuse nuclear localization of beta-catenin. So you can see that pretty much all the tumor cells have nuclear staining for beta-catenin as well as diffuse cytoplasmic staining, but really no significant membrane staining. So at the time of original diagnosis, as well as when the patient came to our institution for as a referral, several immunohistochemical stains were performed, and most of the other pertinent immunostains, including chromogranin, NUT, sulfur, TTF1, hormone receptors, P40, were all essentially negative. Of note, mismatched repair proteins were intact in this case. So the diagnosis for this case is a pilomatrix-like high-grade endomatured adenocarcinoma involving the ovary. So some follow-up. So after her left salpingo oophorectomy, imaging showed that the patient actually had pulmonary metastasis. So when she presented with fibrous stage 4B disease. She then received chemotherapy, and after 6 cycles of chemotherapy, she underwent an interval total abdominal hysterectomy, right salpingo oophorectomy, as well as staging biopsies. Of note, there was no tumor in the endometrium or the right ovary, and the staging was completely negative. She finished 3 more cycles of chemotherapy, and at last follow-up, which was only 12 months because this was a recent case, the patient was alive without any evidence of disease. So we're going to talk a little bit about pilomatrix-like endometrioid adenocarcinomas. These tumors were formally described, I would say, in 2022 by Weissman and colleagues. These tumors have very characteristic histologic, immunophenotypic, and molecular findings. So the histologic findings, as you can see over here, are this typical nested pattern that we saw with basaloid tumor cells, geographic necrosis, and prominent squamous differentiation with shadow cell formation or ghost cell keratinization, as they call it, resembling cutaneous pilomatrix carcinomas. From an immunohistochemical standpoint, very importantly, these tumors are negative for Mullerian markers such as PAX8 and SOC17, and they also have loss of ER and PR. They have variable expression of CDX2 and neuroendocrine markers as well. The most important thing, of course, is that there's aberrant nuclear beta-catenin localization, and this corresponds to the fact that these tumors have CTNNB1 mutations, particularly in exon 3. Most of these tumors fall in the no specific molecular profile or NSMP category of endometrial carcinomas because they show wild-type P53, they are mismatch repair proficient, at least in the original report, and also they don't have polymutations. The outcome for these tumors is invariably poor. As you can see, most patients present with advanced stage disease and succumb to their disease within 24 months of diagnosis. Just to recap the histologic features, again, please pay attention to the fact that you have these large basaloid nests, geographic necrosis. This appearance from low power really should make you think about this entity right away. On high power, you can see in these 2 images a little bit better representation of the shadow cell formation or ghost cell keratinization, which is very, very characteristic of this tumor. But like I said in our case, it was a very focal finding. So in some cases, it may be readily identified, and in other cases, not so much. So after this initial description, there was another expanded series of these tumors, and in this series they found both mismatch repair proficient as well as mismatch repair deficient tumors. And in this case series of 13 cases, most patients, as you can see, presented with FIGO stage 4 disease, particularly with metastases to lung, liver, bone, and brain. Almost 80% of the patients died of their disease. Of note, all 6 mismatch repair proficient patients died of disease, and 4 of the 7 mismatch repair deficient patients died of disease. CTNM1 mutation, B1 mutation, was identified in all the tested cases. So the initial reports, as you can see over here, were all in the endometrium. But since then, there have also been reports of this particular tumor arising in the ovary. But if you go back in time and you pay attention, actually similar tumors were described as early as 1996. But somehow the terminology and the entity just didn't catch on till it was described with better molecular characterization in 2022. But you can see that there are at least 3 different papers describing the exact same histologic features in ovarian tumors. These tumors of this particular morphology can also be seen in gastric tumors, and we recently had a case of a tumor in the bladder that showed a similar morphology. The differential diagnosis includes FIGO grade 3 endometrial adenocarcinoma, undifferentiated or dedifferentiated carcinomas, large cell neuroendocrine carcinoma, and squamous cell carcinoma. In a small cervical biopsy, you can see with all the characterization how you can easily mistake this for a squamous cell carcinoma, and more so even in a metastatic site. In these cases, you can easily do high-risk HPV, and that should resolve the diagnosis for you. Both FIGO grade 3 endometrial adenocarcinomas and pyelomatrix-like carcinomas can have squamous differentiation. However, usually in FIGO grade 3 tumors, the nuclear atypia is not as prominent as it is in the pyelomatrix-like carcinomas. They also don't have large central geographic necrosis, and specifically, they don't have the typical shadow cells or ghost cell characterization. Most FIGO grade 3 endometrial carcinomas do express at least 4 Mullerian markers such as PAX8 and SOC17, and also have hormone receptor expression. They are typically negative for synaptophysin, but CDX2 can be focally positive in these tumors. Dedifferentiated and undifferentiated carcinomas can also enter the differential. Both are solid, high-grade tumors. Both can have basaloid-appearing nuclei. But some differences include the fact that pyelomatrix-like carcinomas have a more nested pattern, whereas undifferentiated or dedifferentiated carcinomas tend to be a little bit more discohesive. Both can have abrupt characterization, but the presence of shadow cells and ghost cell characterization is not typically seen in undifferentiated or dedifferentiated carcinomas. Conversely, rhabdoid morphology, which can be seen in a subset of undifferentiated carcinomas, is not typically seen in these tumors. And consequently, SMART-A4 loss can be seen in those kind of tumors that have rhabdoid morphology. So it's seen in undiff carcinomas, but not in the pyelomatrix-like. Please pay attention that both synaptophysin can be positive in both tumors. Another very important marker is pankeratin. Pankeratin is typically decreased or negative in undifferentiated carcinomas or dedifferentiated carcinomas. However, they tend to be diffusely positive in the pyelomatrix-like carcinomas. In the report that we had, there was a few cases of dediff carcinomas that can be diffusely keratin positive, but they are in the minority. With respect to beta-catenin, we had a recent abstract that we submitted to this year's USCAP. We had a total of 30 cases of undifferentiated and dedifferentiated endometrial carcinomas. And as you can see, almost 25% of them had at least variable expression of beta-catenin. So beta-catenin alone cannot be used to distinguish undifferentiated or dedifferentiated carcinoma from pyelomatrix-like hybrid carcinoma. And you really do need to pay attention to the entire morphologic and immunophenotypic appearance of the tumor to make the distinction. Last but not the least, Larsen neuroendocrine carcinoma. Even from low power, you can see that the histologic features with the central necrosis, basaloid nuclei can really show overlap with pyelomatrix like high-grade endometrial carcinoma, and not to mention the positivity for synaptophysin and CDX2 can further confound the picture. However, as mentioned in other tumors, prominent characterization including shadow cells and ghost cell characterization are not characteristic features of large cell neuroendocrine carcinoma, and so you must bear that in mind when you're trying to make the differential, particularly in metastatic sites. So in summary, one should think about pyelomatrix like high-grade endometrial adenocarcinomas when you have tumors with basaloid cells, central geographic necrosis, and characterization with or without shadow cells. And when you see that, you should prompt staining at least for certain markers such as beta-catenin, synaptophysin, CDX2. And why is it important? It's important because these patients usually present with advanced stage disease and have a really bad prognosis. So it's important for the clinicians to be aware of this entity. Since it's a relatively newer entity, many clinicians are not very familiar with it, so there's a certain level of education that needs to happen with our clinicians to explain to them. They are usually mismatch repair proficient, but as has been shown, they can be mismatch repair deficient. And in these cases, there are rare reports of patients having dramatic response to immune checkpoint inhibitor therapy. Therefore, testing MMR on all of these cases is particularly important. Our case is very interesting for a few reasons. One, it's an ovarian primary rather than an endometrial primary, and also there isn't a low-grade, endometrial carcinoma component that was at least initially described in all of these tumors. So there are a few reports, and there's actually one report of so-called transdifferentiation because the tumor has no low-grade component. In our case, the shadow cells were not prominent, and therefore it will be easily mistaken for another entity. And also, our patient had excellent response to therapy, and usually these patients succumb to their disease within 2 years. So I thought this was a very interesting case to present for multiple reasons. Thank you so much for your time.
Do you have any questions, comment? Yes, please.
Thank you very much. How can we tell apart, and if you would consider in the differential diagnosis, the teratoma with somatic type malignancy too?
Essentially it's a sampling issue, right? So if you have any kind of somatic malignancy can happen in a teratoma. In a young patient, that's a very good point. It's certainly a possibility, but you would have to sample the OB to see if you can identify other teratomatous elements. Because if you don't find that, then it would be very hard. Certainly, there's a possibility that the tumor overran the teratoma, and there will be, hard to prove, but it would really avoid down the sampling.
Thank you.
Let's move to the next case, presented by Dr. Perez.
The next case is a 44 years old woman with transvaginal bleeding, treated in another hospital as a previous case. The patient had a cervical biopsy with a diagnosis of only carcinoma NOS, but because the transvaginal bleeding was very profuse, the hysterectomy was done. We received only slides and some paraffin blocks, and in the first impression that we thought that the material was bad preserved, but we can see in some areas like down here that you can see the glands are preserved. So maybe it's not the tissue, it's the tumor. So we saw in some cases, in some areas, this diffuse pattern, like here. And in other areas, you can see these like more discresive areas with this pseudoalveolar pattern. between the proliferation of the neoplastic cells. You can see here all the glandular, endometrial glandular residual glands in the middle of the tumor. This is areas where you can see the infiltration to the myometrium, some vascular invasion, and you can see how the tumor is infiltrated between the muscle. In the surface of the tumor, you can see here residual endometrial epithelium with this polypoid groin, and this we have here the diffuse pattern of the lesion. Closer, you can see the glands are not neoplastic. You can see here the epithelium, and here the infiltration by the tumor. Closer, we have these monomorphic cells, proliferation of cells. The cells have a scan cytoplasm. Some of them have this cohesive pattern, and in some of the areas you can find this cytoplasm very eosinophilic with, like here, like this area, and looks a little bit like a rhabdoid features. In another, you can find this kind of stroma, is a little bit myxoid with all these kind of cells that are more monomorphic. So we did immunostains, everything was negative. Everything that you can order was negative. But SMART4, we don't have expression, and this is the example of the case, and we have the internal control here. So the diagnosis was SMART4 deficient uterine sarcoma. This is a subgroup of indifferentiated uterine sarcomas that can be small or medium cells with rhabdoid features. But the rhabdoid features sometimes are very focal, and sometimes are very difficult to find them. There are some cases reported in rhabdoid tumor syndrome, and the age of the patient, there are a young patient, is 36, between 34 and 49, and they present with many uterine masses with a vaginal rhythm. And there are something that is very interesting in that cases, that many of them have a metastasis to the lymph nodes. So, are you thinking in a sarcoma with a metastasis to the lymph nodes? Okay, great. So, these kind of mesenchymal tumors are very rare. You can see that the distributions of this kind of tumors, and actually the SMART4 mutation is described in another kind of gynecological tumor, made in the ovary with the small cell carcinoma hypercalcemic type. But there is something very interesting with this change, because this kind of the differentiation you can see in head and neck, in carcinomas of the head and neck, you can see inside in pancreas. Actually, you can see in endometrial, as let's say before, in undifferentiated carcinomas of the endometrium, and you can see even in a mucinous neoplasia of the ovary with malignant nodule. But in this point, maybe you are asking why we are call this kind of tumors sarcoma and not carcinomas. We are going to see them later. And this change, this differentiation, apparently is between the epithelial mesenchymal transition, and these neoplasias are very, very aggressive. Histologically, is a diffuse growing of cells with corded and phylloid-like structure. The cells are monotonous, can be medium or small cells with epithelioid morphology, and some rhabdoid areas with this eosinophilic inclusion in the cytoplasm. The nuclei are round, they are monotonous, have a necrosis, can have a lymphovascular invasion, and can have some change of the stroma, like a mixed change. And very interesting, in trap or compressed native endometrial glands. This kind of uterine sarcomas can have another deficiency, but the immunostains per se is not diagnosis. So you have to rule out another diagnosis to do this diagnosis especially. Some of the stains that help you to do the differential diagnosis is the mismatch repair and P53, and we are going to see one example. This is another case that you can see as neometrial with this exophytic and polypody lesion. And we have here residual epithelial areas. We have here the mixture between the glandular component that is looks benign and the rest of the proliferation of the cells that you can remember some cases that present Dr. Fukunaga or present Peter. This is an indifferentiated lesion, and you can see here the residual glands, benign glands. So we order immunostains, but in this case, the mismatch repair was lost and P53 was mutated. So what did we reverse? With more cuts, and we can find a very focal area of adenocarcinoma. So this is an undifferentiated uterine endometrial carcinoma that is the main differential diagnosis. And it's important because the treatment is completely different. So we have to do the effort to do this differential diagnosis. You can see the difference between the undifferentiated carcinomas and the SMART4 deficient uterine sarcomas. We have difference in the age, we have difference in mismatch repair protein, and we have, if you are lucky and you have all these mutation, way to do it, is very helpful. But if not, you can do immunostains. This kind of lesion have been described too with hybrid adenosarcomas and sarcomas in the same neoplasia. Many of us, we thought that it's the same neoplasia with a very high undifferentiated areas. So, but one is because this patient have a metastasis to the lymph node that is not frequently to the sarcomas. And the other is that if you do a very good ROS, you can find some areas of a residual adenocarcinoma. The differential diagnosis is another undifferentiated neoplasias with rhabdoid features that include pecoma, lymphoma, melanoma, epithelioid sarcoma, or high endometrial stromal sarcoma that we saw before. But something that is very important is gross well the specimens. If you don't gross well the specimens, you are going to lose the diagnosis. So as in gynecological area, we have these large tumors, but we have to be very conscious about the importance of the growth of the specimens of the correct way. Only for finish the differential diagnosis is with another rhabdoid lesions, like in this example in the cervix, that we can find these rhabdoid and plasmacytic areas that are HMB45 positive, S100 positive, and SOX10 positive that correspond to the melanoma in the uterine corpus. So the SMART4 deficient uterine sarcomas is important because the treatment with the undifferentiated carcinoma is completely different, and now there are very recent articles about the treatment of this kind of tumors with anti-PD-L1. So it's important to do it. Apparently are not associated with mismatch repair loss of the proteins, and there are some case reports with responses to the radiotherapy. So only when you are seeing an undifferentiated neoplasia with these rhabdoid features, these quested cells have to be very extensive crossing because you have to rule out carcinoma, undifferentiated carcinoma, before to do the diagnosis of a sarcoma, this very rare sarcoma. And remember that we don't have special stains, specific stains for the diagnosis, and the diagnosis is rule out another tumors. Thank you very much.
Thank you, Delia. Any questions? Okay, Dr. Go ahead.
So, thank you. Julia, thank you for that presentation. So, differentiating undifferentiated carcinoma from SMARC deficient, both can have SMARCA4 loss. So, if you have a mismatch repair proficient, tumor, and given that keratins can be positive and low, and you don't have a low-grade, endometrioid or another type of adenocarcinoma, do you rely mostly on molecular to try to tell the difference between the two, or any other suggestions?
No, we don't have molecular studies. I can do P53, for example, that is associated with carcinoma. They are more frequently with carcinoma and not with this kind of tumors. So it's more useful for us, P53.
Yeah, thank you.
Dr. Ramalingam?
Okay, so I'm back with my second case. This case was that of a 51-year-old female who presented with pelvic pain and vaginal bleeding. She had a transvaginal ultrasound that showed a 4-centimeter mass in the endometrium. She had an outside endometrial biopsy that showed a fibro-grade 2 endometrioid adenocarcinoma. And she came to our institution for definitive surgical management. She had a TH-PSO with sentinel lymph node sampling. So the tumor finally measured 5 centimeters, and over here you can see that it's a large tumor, very solid even from low power, and also invading the myometrium. So the tumor did invade into the outer half of the myometrium. Over here, please pay attention to the fact that there's multiple foci of lymphovascular space invasion. At the end of the entire resection, the sentinel lymph nodes were negative, the cervix was negative, the ovaries and tubes were negatives, the final fibro stage was a fibro stage 1B. So closer look at the tumor cells, you can see that we have essentially a solid tumor, but I want you to pay attention to the presence of these scattered, really pleomorphic cells that are randomly distributed between the other tumor cells. The arrows point to them. Some of them have this kind of smudgy nuclei, and the remainder of the tumor also looks quite atypical and solid. There may be some areas of attempted gland formation, but essentially most of the tumor was solid. In this particular image, again, you can see nests of tumor cells. Here it has a little bit more of a squamoid appearance, but please pay attention to the brisk peritumoral lymphoid infiltrate. Some parts of the tumor, as you can see over here, had cytoplasmic clearing, very prominent cherry red nucleoli, raising the possibility of a clear cell carcinoma component. However, as usual, the immunostains for clear cell carcinoma were not helpful. This is a big frustration for us, particularly in endometrial tumors. Napsin was negative, and P504 as shown positive staining here and there, but it was non-specific because it was also positive in other more glandular type areas. The tumor did show expression for PAX8 and was negative for estrogen receptor with appropriate internal control staining. Of note, the tumor had this pattern of P53 expression, otherwise known as subclonal aberrant expression of P53. You can see that the background tumor, as you can appreciate over here, shows very nice wild-type staining. So the majority of the tumor had wild-type P53 expression, but certain areas had overexpression with the so-called subclonal overexpression pattern. The tumor was mismatch repair deficient. The patient underwent molecular testing, and there were 2 abnormalities in addition to others, several others, because the TMB was 341, was a pathogenic mutation in poly as well as a TP53 mutation. So putting everything together, the final diagnosis for this case was a polymutated FIGO grade 3 endometrioid adenocarcinoma. So we're going to talk about polymutated cancers. But just for some follow-up, the patient did have vaginal brachytherapy and is currently alive without disease 24 months after original diagnosis. So after giving this topic, I realized that I probably took on a little bit too much for a 15-minute talk, because poly is pretty vast, and the pile of carrots over here is really a reflection of the number of papers that have been published on this topic in the last 5 years particularly. I had to do a lot of reading very fast, and my mind is also looking like this pile of carrots. But I'm going to try my best to kind of consolidate the information, at least to highlight the salient features. So before we move forward, we really sometimes have to look back to see where we started, and we have to go back to 1983, okay, where the dualistic model of endometrial cancer was proposed by Bachman. And this dualistic model served us really, really well for 30 years, and many treatment decisions were made based on the diagnosis of whether the tumor was endometrioid and the grade and non-endometrioid, and clinicians, made treatment decisions based on those diagnoses. However, as we all know, the reproducibility for high-grade endometrial cancers is not very good, even amongst expert gynecological pathologists. So you really never got the exact right answer, and sometimes the morphology didn't correlate with clinical outcomes. But all that changed in 2013, where the Cancer Genome Atlas Research Network, or the TCGA, proposed the molecular-based classification of endometrial cancer and essentially divided endometrial cancers from a molecular standpoint into 4 groups: the poly-ultramutated, the MSI or hypermutated, copy number low endometrioid type tumors, which are otherwise known as no specific molecular profile, and then the copy number high or the P53 abnormal type. So based on this, we at least know that we have 2 separate categories of tumors. One with the poly, which is a really good actor, and on the other end of the spectrum, you have the P53 abnormal tumors that are the bad actors. And then in between, you have tumors with varying degrees of clinical and pathologic correlation and outcomes. So let's talk a little bit about polymutated endometrial carcinomas. This results because they have mutations in the DNA polymerase epsilon, impairing its proofreading functions. This results in an ultra-mutated phenotype, and therefore you have a very, very high tumor mutational burden, often more than 100 mutations per megabase. But having said that, there's all this buzz about poly, but they only represent about 5 to 10% of all endometrial cancers. But still, that's the one that's winning all the races right now. These tumors occur typically in younger women. And from a pathology standpoint, they have some very characteristic histologic features such as high-grade morphology, also morphologic heterogeneity, as we saw in this case, resembling areas of clear cell carcinoma, sometimes serous-like, deep myometrial invasion, multifocal lymphovascular invasion, and despite all of these high-risk factors, they still seem to have an exceptionally good survival outcomes. At least that's what the literature says, with almost greater than 96% 5-year survival. But before we move forward, what we need to understand is that all polymutations are not created equal. So the polymutations have to be within the polyexonuclease domain site, and only those are pathogenic, and only those tumors with pathogenic polymutations have this outstanding, excellent clinical outcome. And here are the topmost 5 hotspot mutations, and most of the polymutations occur in these codon sites. Just to recap the morphologic features, again, we talked about the presence of these bizarre nuclei that are randomly distributed with smudging nuclei, as you can see here. And also the tumors have pretty robust peritumoral lymphocytic infiltrate. Please pay attention to this particular area where you can see that the atypia is so prominent that it really has compelling features for a serous carcinoma or serous-like features. So why should we test for choline mutation? Well, firstly for better diagnostic accuracy, and we're going to talk about that in the next couple of slides, to identify the so-called multiple classifiers, and also to recognize a group of tumors that have excellent prognosis, and even in the PORTEC-1 trial, even in patients who did not have adjuvant therapy, the patients who had choline mutated tumors had a much better prognosis than choline wild-type tumors. And the argument is that the response to adjuvant therapy is also not that great. So if they do recur, then it's better to treat them at the time of vaginal recurrence because the salvage rates are so high that it didn't make sense to give these patients upfront radiation therapy. So those are the discussions that are going on in the GYN oncology literature. And of course, the presence of the choline mutation is also kind of like a basis for de-escalation of therapy, particularly for patients with stage 1 or 2 disease, even if they have high-grade morphology. So here's a high-grade endometrial carcinoma. Again, you please pay attention, pretty significant nuclear atypia throughout the tumor, presence of several mitotic figures, so certainly has a compelling evidence to consider the possibility of a serous carcinoma. P16 is diffuse and P53 shows a null pattern. So is this a FIGO grade 3 tumor or is it a serous carcinoma? With this kind of diffuse P16, that kind of morphologic atypia and null P53, one could make a really good argument for this being a serous carcinoma, and that's what you would probably say if you didn't have the luxury of having the molecular profile. The NGS testing, however, revealed a pathogenetic choline mutation. So then what's the answer for this? So is it a choline mutated tumor and the P53 is a secondary passenger mutation rather than a driver mutation? So even with this kind of high-grade atypia, abnormal P53 expression, it looks like choline is the one that trumps. So this would be considered a choline mutated tumor even though it has P53 abnormal features. Here is another example of a FIGO grade 2, a stage 1 FIGO grade 2 endometrial carcinoma that has both choline and TP53 mutations. Over here, please pay attention to the surface slackening appearance that has been described in a group of, in some cases of choline mutated tumors. And over here on the right-hand side, you can see that there is definitely subclonal aberrant expression of P53. And you can see more wild-type staining in the lower grade areas. Pay attention to the TMB, which is 688. In this particular case, you have a choline mutation, again in one of the hotspots, plus numerous, missense mutations in the TP53 gene. So again, based on morphology, you may consider this to be a serous or a serous-like carcinoma, but now you have a choline mutation, and again, in this case, the TP53 is currently considered to be a passenger mutation and not a driver mutation, and overall, the tumor is considered to be a choline mutated tumor, and in which case, these patients are not necessarily subject to chemotherapy, if at all radiotherapy, depending on the clinical factors, or no therapy at all. So those are the current options that are being advocated. So this brings us to the multiple classifier tumors where you have choline mutation along with P53, mismatch repair deficiency along with P53, or choline mutation and mismatch repair deficient. When you have poly or mismatch repair plus P53, they are still considered to be poly or mismatch repair deficient respectively, and they are not considered to be P53 abnormal tumors. Therefore, they should be treated as you would treat a choline mutated tumor and have at least a discussion about de-escalation of therapy for these patients. So therefore, it seems that without poly, you really cannot get the right answer, right? So if you have a mismatch repair deficient tumor, but you have poly, or if you have a P53 abnormal tumor and you have poly, then you have a different answer than if you have a non-pathogenic poly or just a pure TP53 mutated tumor, which puts you into a different line of clinical management. So it would appear that a poly-driven molecular classification, unlike the promise, is a better mechanism by which we can try to identify which kind of tumor should receive what kind of treatment and what kind of molecular classification they should have. So if we follow this ESMO clinical practice guideline, that would mean that you would have to do polymutation analysis on pretty much all endometrial cancers. But as we know, polymutation analysis is expensive, also not widely available in many laboratories. So now you're stuck with this conundrum of having to order this on all the tumors. So should we be ordering poly on all the tumors? Well, if you're a tertiary care center or if you're in a center where you have access to that, for sure, but for those that don't have that ability, there's an option to do a targeted molecular testing for endometrial carcinomas, depending on whether you do the testing on the biopsy or the surgical evaluation. So please pay attention that if the tumor has high-grade features or is mismatch repair deficient or is P53 abnormal, then those patients are the ones that are more likely to benefit from poly testing. If you have a low-grade tumor with low-risk factors, then those patients are probably not going to get adjuvant therapy to begin with. Therefore, the poly testing is really not adding any value to the management of these patients. So a more targeted approach may be of benefit. So in summary, I would like to say that polymutated endometrial carcinomas have excellent outcomes in most patients, regardless of their histotype. Therefore, in a high-grade tumor, unless it's an obvious serous carcinoma or obvious carcinosarcoma, it would really be important to know what the poly status is. From a pathology standpoint, I'll be done just a minute. From a pathology standpoint, the key histologic features are high-grade morphology, ambiguous features, lymphoid infiltrate, mismatch repair deficiency, and subclonal P53 overexpression. If you see these features, then maybe as a pathologist you can say, hey, why don't you do poly testing on this rather than doing it on a low-grade, grade 1 or 2 tumor. And this would give the clinician very important information to consider the possibility of de-escalation or increased escalation of therapy as the case may be. So I think we're all moving towards a histomolecular classification of endometrial cancers. It's a reality for us. We have to learn to embrace it and move forward with it. Thank you for your time.
Any questions? No, let's move to the last case before the lunch. Presented by Dr. Klubickova.
So good morning, dear colleagues. I'm Dr. Klubickova, as you probably noticed. Unfortunately she couldn't make it, so I'm presenting instead of her. But it's our joint project, so it should be hopefully okay. So case 31, it was a 34-year-old patient with an unremarkable polypoid lesion of the uterine cervix measuring 8 millimeters, and a single excision was performed. And I'll try to take advantage of being on the home turf and actually show you the real slide, scan slide. So you can see very small polypoid lesion, which was on the cervix, covered by unremarkable endocervical mucinous epithelium. This is the base, probably. Again, normal glands here. You can also see inside of the tumor scattered glands, just entrapped, everything normal. So the main tumor, the main lesion is here. This is this hypocellular gland spindle cell proliferation. Really no atypia, no mitotic activity whatsoever, no necrosis. And actually the most striking features are these scattered small vessels with hyalinized walls, which were present throughout the tumor, roughly equally spaced. and there was nothing more to help you. Okay, I have here also some pictures because I want to make sure that we will have something to show. Okay. So now the immunophenotype. We did CD34, which was diffusely positive. S100 protein was diffusely positive, so you can think of some neurogenic tumor. But Suster was completely negative, so most likely not neurogenic tumor. And very helpful stain for these tumors is CD30. It's diffusely positive as well. So actually this case was sent to me about 2 years ago by a friend of mine from Slovakia, and it was like 2-3 weeks after I presented at some seminar in Czech Republic about these kinase fusion positive spindle cell tumors of soft tissues. So he sent me this case from uterine cervix and said, Michael, this looks identical to the cases you were talking about in soft tissues, isn't it the same? So I look at it and I said, he's completely right, but I've never heard about this, low-grade tumors being described in the uterine cervix or uterine body. So I did molecular testing, DNA and RNA panel was used, no fusions were detected, no NTRK fusions, but we found EGFR mutation, which has also been described in soft tissue tumors with kinase gene alterations. So our diagnosis was spindle cell tumor of the uterine cervix with EGFR mutation within the spectrum of NTRK rearranged spindle cell neoplasms. So this is an emerging entity in the WHO classification of both soft tissues as well as GY NTRK. Unfortunately, the name NTRK rearranged is unfortunate because many tumors don't have NTRK abnormalities, but they have fusions of BRAF, RET, RAF1, MET, and other kinase genes. Or sometimes they have point mutations of BRAF or EGFR, as seen in our case. So I had this case, I thought it must be super rare, and then like 9 months after it, or within less than a year, I got my batch of routine general surgical pathology biopsies. I do soft tissue pathology, but also general search path. So I got my colon adenomas and skin nevi, and also cervical lesions, cervical endometrial curettage and cervical polyps. And there was identical case in just a routine wild type, case, just in the routine practice. So we have 2 cases now, and we could publish a small series of these identical tumors. So just very briefly about NTRK rearranged spindle cell neoplasms of the uterus. They have been described, a few dozens of cases were described, but they were always much more cellular, much more atypical, on the higher grade end of the spectrum from what we know in soft tissue pathology. So none of those described had this low grade hypocellular morphology. All cases were in premenopausal women, or most of them. They were usually centered in the cervix. Very few cases were centered in the uterine body, so most cases were in the cervix. But none of them has been so small and polypoid as the case I've shown you. And as I mentioned, all the cases described were very cellular, basically fibrosarcoma-like morphology. Very often they have CD34 and S100 co-expression. And apart from one case with RET fusion, all other cases described in the GY tract had NTRK1, 2, or 3 fusions. So our 2 cases were in 34 and 46-year-old women. Both tumors had identical morphology. Small cervical polyps, 8 millimeters in greatest dimension, both of them, and both had this very prominent perivascular ionization. Same immunoprofile, CD34, CD30 positive, S100 positive, and SOX10 negative. Both had EGFR exon 20 mutation and flat copy number profile, which was consistent with its very bland low-grade morphology. Okay, this is the other case. Really identical looking. Very briefly on EGFR mutations in mesenchymal tumors. All mesenchymal tumors with EGFR mutations described before were either in soft tissues or in kidney. So the EGFR mutations are either internal tandem duplications of the whole kinase domain. Those alterations are seen in infantile fibrosarcoma, or basically the same tumor with different name, congenital mesoblastic nephroma. It's called congenital mesoblastic nephroma if it occurs in the kidney. If it occurs in soft tissues or elsewhere, it's called infantile fibrosarcoma, but they are basically the same tumors. Alternatively, you can have small-scale exon 20 duplications or insertions, as seen in our cases. Those alterations have been also seen in fibrous hamartomas of infancy. And then 3 cases within the spectrum also of N-TRK rearranged spindle cell tumors, but described or reported descriptively as lipofibromatosis-like or DFSP-like morphology. Importantly, again, none of these cases described before has been located in the uterus. The first case I had was included in our large study on kinase altered mesenchymal tumors, which was published in Journal of Pathology. We had some 23 cases, mostly located in soft tissues, but also some from the GI tract and GYN tract. And we did clinical pathologic analysis and also methylation analysis. And you can see here on the methylation plot, when you analyze, basically using statistical methods, the methylation profiles and compare it to various other soft tissue tumors, you can see that all the tumors with kinase gene alterations cluster together and very close to infantile fibrosarcomas, which are currently considered to be a different WHO entity, but there is an ongoing debate whether these so-called N-TRK rearranged spindle cell neoplasms and infantile fibrosarcomas are the spectrum of the same entity or 2 different entities. We will see how it comes out, but the methylation profiles are very similar. And you can see here, case 22 is the cervical case, the first case we had, and it clusters basically in the middle of kinase fusion or kinase altered mesenchymal tumors of soft tissues. So briefly, differential diagnostic considerations. The most common differential you'll be thinking about is fibroepithelial stroma polyp, because they're just so common. The morphology can be somewhat similar, as you can see here, but there is not such a prominent perivascular hyalinization, and the immunoprofile is different. CD34 is diffusely positive as well, but S100 and CD30 is always negative. I actually tested like 20 of them. Another potential differential is superficial myofibroblastoma, or as we sometimes call it, myofibroblastic polyp. Again, somewhat similar morphology blend spindle cells, but there is no perivascular or prominent perivascular hyalinization, and again, same immunohistochemical differences. The third differential is actually, I don't think you would think about this tumor because it just looks completely different. It has high-grade morphology, but I included it here just to kind of raise awareness of this most likely a new emerging entity in GYN pathology described by Abbas recently with our support. So these tumors, again, most commonly occur in the uterine cervix, but some have been more like in the uterine body. They have high-grade, undifferentiated spindle cell or round cell morphology, or mixture of these two. There is basically no stromal, no prominent stroma, no perivascular hyalinization. There is also S100 protein expression, but there is also diffuse SUX10 expression. So you may mistake it for maybe poorly differentiated melanoma. But they are different. They have ERBB2, basically HER2 or HER3 mutations or amplifications or both. They are very aggressive, but given the molecular background, they may be maybe targeted therapy could be helpful for these cases. So in summary, the spindle cell tumor with an EGFR mutation is an exceedingly rare lesion of the uterine cervix. I actually, when we were writing the paper, I pulled out I've got one case from routine practice, so I asked for the next 500 cases synovial cervical polyp, or next 499 cases synovial cervical polyp, and I was hoping to find one more or 2 more cases, but there was nothing. So it's definitely less than 1 out of 500 cases of cervical polyps, probably much less, so exceedingly rare. It's at the low-grade end of the spectrum of N-TRK rearranged spindle cell neoplasms. The most striking morphological feature is the perivascular hyalinization, and you can support the diagnosis with immunohistochemistry. A few somewhat similar cases have been described outside of the GYN tract, but not in the uterus yet. Our 2 cases were first described there. And actually the main question here is, because in soft tissue, we know these low-grade tumors sometimes within the same tumor may progress, may transform into a high-grade spindle cell sarcoma, which may be sometimes aggressive. Or it can happen in the recurrence. When the cases recur, the cases that used to be low grade will recur as high grade spindle cell neoplasm. So the same question is here, whether these tumors can transform into a high grade variant or not. And if so, it might be important to diagnose them correctly, because the EGFR inhibitors could be useful for their therapy. So thank you for your attention. That's all for this case.
Any questions or comments? With that, I'd like to thank everybody from this morning for a very interesting session, and hand over the reins to Joran and Hugo for the next session around 6.
Thank you very much. So we switch gears our session for thoracic and soft tissue pathology. Myself, Göran, and Belgium from Sweden, from Mexico, the moderators. We are slightly behind the schedule, but we have in total 10 interesting cases. 3 of them will go before lunch. So please go ahead. Our first speaker this session will be David Suster.
Okay, thank you. I think this case might be mislabeled. It should be case 32, but we can fix that after the fact. Forget how this thing works. So we'll start with the first thoracic case, and this is kind of an unusual entity. I presented some of this work at the IP in Cancun a few months ago, but this was just recently described. So we'll start with the case. This was a 73-year-old male with no real significant past medical history, and he had hypertension, presented with cough, dyspnea, and chest pain. And he had a chest imaging because of the symptoms, and it actually demonstrated a very large right upper lobe tumor mass. So you can see here a composite imaging from that patient. And on the left side is the axial CT scan. There's this thing here. So right there you can see there's this relatively large mass that's attached to the pleura. It's irregularly spiculated, so just that size and that sort of pattern in a lung CT scan is concerning for a malignant tumor. And you can see on the coronal fused CT PET scan, in the upper lobe, in the right upper lobe, there's this like very avid tumor mass. So concerning, all of that imaging is lining up for malignancy. So the patient underwent a core needle biopsy, and this is from the core. So, you see an infiltrative process. There's like nests of atypical cells in here. And it looks, the nests are pretty solid. It almost has like a squamoid look to it, maybe a little bit baseloid, maybe not. We did IHC on it, and it had napsin and TTF1, so signed out as poorly differentiated carcinoma, and was thought to be an unusual solid pattern adenocarcinoma, and they proceeded to take out this tumor from the patient. So this is the lobectomy, and you can see there's this very large, firm-looking tan white subpleural mass. There's central areas of degeneration and necrosis. And the mass measured approximately 6 by 5 centimeters, and aggressive-looking tumor. But just from the gross, you can't really tell exactly what this is. The squamous cell can look like that, adeno can look like that. Neuroendocrine tumors can have that same sort of like white tan cut surface. And this is the low-power histology. So what you see is this sort of fibroinflammatory stroma. And a very infiltrative, kind of purple-looking tumor, almost basaloid-looking, very solid, no overt evidence of gland formation, right? Like when you first take a look at this, you wouldn't immediately think this is an adenocarcinoma. You'd probably think of a squamous cell or possibly solid pattern adeno or something else. This is slightly higher power, so you can see these small little infiltrative nests. On the right side, there's possible lymphovascular invasion, or it could be retraction artifact. It's hard to tell. But you can see that the cells are very large. They have these hyperchromatic nucleoli to them with an ample, sort of rim of eosinophilic cytoplasm around them. This is higher magnification. So again, some of these have a pretty good rim of cytoplasm around the outside of the cells. They kind of have like large cell morphology, if you will. Some prominent cherry red nucleoli, and maybe I could convince some members of the crowd, like in the top part of that image, that there's a vaguely stippled appearance to the chromatin pattern in there, so what you kind of see in conventional neuroendocrine tumors. There's other areas like this that had this, very prominent peripheral palisading. So, you have this basaloid-looking tumor, large cells, peripheral palisading, and then real prominent areas scattered through the whole tumor that look like this. So, comedo-like necrosis like you would see in DCIS of the breast, or in atypical carcinoids, or, what I'm sort of trying to drive everyone towards, which is large cell neuroendocrine carcinoma of the lung, right? This image here is pretty classic. I mean, we could get away with putting this in a textbook for an LC neck or large cell neuroendocrine carcinoma of the lung, and no one's going to question you. They just have to take your word for it. But we worked up this whole tumor. Remember, at TTF1 napsin. We worked this thing up, very strong positivity for TTF1 and napsin. TTF1, you can see it highlighting that peripheral palisading. P40 dead negative. INSM1 is shown here is dead negative too. We did additional workup on this thing, including synaptophysin, chromogranin, CD56, basically every neuroendocrine marker we had, because we thought this was a large cell neuroendocrine carcinoma with some TTF1 expression. Negative for every single one of these markers. P63, in addition to the P40 negative. SMARCA4 was intact. PDL1 negative. We did prostate markers even, just because it was, kind of a weird basaloid look to it, and that comedo-like area of necrosis, sometimes prostate, and older male. So just to check, that was negative. And then we sequenced it in very non-specific findings, a TP53 mutation, and then some KIT copy number, very low level copy number changes, and FGFR1. Totally non-specific. So no gene fusions, no characteristic EGFR alterations or anything like that. But we have a tumor that's, strong positive TTF1 napsin and no neuroendocrine markers, despite its neuroendocrine-like growth pattern. So this case actually also got electron microscopy. We don't routinely do EM. I don't know anybody who really does, but this was part of a research study. So you can see there's like this. You can see here on this left side, this dark line are like these tight junctions, epithelial junctions. And the one thing that you'll notice is, I don't know if anyone's ever looked at EM and looked at neuroendocrine tumors, there's no dense core neurosecretory granules here. You can see that on the left side, this stuff down here. This is what they actually look like small little black dots, right? So again, now by EM, because we were so suspicious that this was an LC neck, now by EM we have a tumor with like absolutely no evidence whatsoever of neuroendocrine differentiation. Even though the morphology looks just like a LC neck, I mean, perfect for it, essentially. So we diagnosed this case as a large cell basaloid adenocarcinoma of the lung, or LC-BAC. And there isn't really any category or description of this. We were able to, through our archive and with collaborating with some additional authors, put together like a study of 12 cases of tumors with this exact profile. They look like large cell neuroendocrine carcinomas or basaloid squamous cell carcinomas, but they're just adenocarcinomas with this neuroendocrine-like growth pattern. So this is those 12 cases that was published in AJSP, I think this year, or like late last year or earlier this year in print. Study of 6 men and 6 women, mean age of 60 years. Average size of the tumor, 6.5 centimeters. Every single tumor was TTF1, napsin, strong diffuse, and then uniformly negative for every single neuroendocrine marker, including CD56, which is surprising because in our laboratory, CD56 stains every single tumor we've ever stained it with, except for these. Somehow they're just negative, right? So, pretty convincing that none of them have a true neuroendocrine differentiation or expression. We sequenced those patients, and really the only thing we found were KRAS mutations and TP53 alterations. So no RB1, no concurrent TP53 RB1 loss like we often see in the lung in high-grade neuroendocrine tumors. And clinical follow-up in the patients, there's variably aggressive behavior. So, 2 patients died of the tumors, multiple had distant metastasis, but about half of them were alive and well, 1 to 16 years, depending on, the stage of the tumor. So moderately aggressive tumors. So here's a few more images from cases in that study. So you can see they kind of have like this kind of look to them from intermediate powered magnification. You have these nests, cords, trabecular tumor cells. There's often the comedo-like areas of necrosis seen up here. You can find, like in the top right image, some areas that look like adenocarcinoma. There's some glandular or cyst-like spaces. Some of them have clearing of the cytoplasm, but again, that peripheral palisading is always very prominent, making it look like an LC neck. And then on high power, you can see that, basically aggressive-looking large cell morphology, high mitotic activity. So, these tumors are a little bit confusing because the WHO definitions are a little bit confusing. So it's hard to fit them into any of the existing categories. And I've listed 3 of them that we sort of consider. The first would be a large cell carcinoma, right? You have large cell morphology, but these are defined as undifferentiated carcinomas that have no cytologic, architectural, immune or histologic or EM evidence of adeno or squamous differentiation or neuroendocrine differentiation. So we have TTF1 napsin in this case, so it doesn't fit in there, right? And then the other sort of suspect is large cell neuroendocrine carcinoma, which is a high-grade neuroendocrine tumor that has this organoid or neuroendocrine-like morphology, but by definition has to express at least focally one of the 4 neuroendocrine markers. Even though I have issues with that definition, but even by that very loose definition of any neuroendocrine marker positivity, these tumors don't fit into that, right? And LC necks in the lung generally are TTF1 and napsin A negative. Napsin A negative, TTF1 positive. So our tumors also had the napsin A positivity. And then finally, there is like a mention of this large cell carcinoma with neuroendocrine morphology, but this doesn't really fit into the category of large cell carcinoma because it has some evidence of adenocarcinomatous differentiation. So you wonder, a more appropriate category is almost non-small cell lung carcinoma with neuroendocrine-like morphology, but that's not something that actually exists. So these are unusual tumors. And here's just a comparison slide. These are 2 more cases from our study on the left side, just compared to a true LC neck on the right side. So you can see how similar appearing these tumors are and how easy it would be to confuse these if you weren't really doing all of the markers, which most people will do. But those prominent areas of comedo-like necrosis, a basaloid appearance, large cell morphology. The only difference is you'll have neuroendocrine marker positivity in the LC necks. And then the other main differential is with basaloid squamous cell carcinomas or lymphoepithelial carcinomas, other basaloid squame type things. But obviously those should be TTF1 napsin A negative and have markers of squamous differentiation, so pretty easy to differentiate those. But histologically, you could get nests of basaloid cells with peripheral palisading, so they can kind of be confused. So essentially what we're describing is more or less a quote-unquote new entity or new histologic subtype of adenocarcinoma in the lung, which we've termed large cell basaloid adenocarcinoma of the lung. Very rare. We have only been able to put together 12 cases, and awareness of this unusual variant is important because the treatment and prognosis is so different for lung adeno as compared to large cell neuroendocrine carcinomas in the lung. And these can easily be confused with LC neck or basaloid SCCs. So to diagnose them, it's pretty simple. You just have a tumor that looks like a large cell neuroendocrine carcinoma and all your neuroendocrine markers are negative, and you have TTF1 and napsin, it's one of these things, okay? And that's everything. So thank you very much. I'm happy to try to answer.
Thanks, David, for presenting this very interesting and important pitfall. Questions, comments?
Any molecular data?
Yeah, they were all sequenced. 6 of the 12 cases had KRAS mutations, so pretty good for adeno profile. And then I think like 6 or 7 had TP53. So nothing specific or diagnostic that you could find in there, but no RB1 alterations.
Thank you.
Yeah.
Okay, thank you. I think we move on to next case 33, Dr. Larsen.
All right, it's my pleasure to be here and appreciate the organizers for the invitation to present a couple of cases. And I know that I'm the guy that's right before lunch. So I don't want to stand between you and your food, and more importantly, the barrel of beer that's downstairs, getting nice and cold. But so the first case I'll share with you is one that I got about a year ago in our in-house practice. This was a 40-year-old man who had no prior medical history, otherwise healthy, and he had increasing shortness of breath. And they did imaging, and they found this 4.2 centimeter mass in the pulmonary artery. And you can see there the space-occupying lesion there, and with the arrows pointing to it. And this was biopsied in an outside hospital, and they called it a spindle cell neoplasm, but they couldn't further classify it with a bunch of stains. And because of the location of the tumor, it was presumed to represent an intimal sarcoma in the pulmonary artery, but MDM2 FISH was negative. But the clinician said, well, this has got to be an intimal sarcoma, right, even though the MDM2 FISH is negative, so they treated the patient with neoadjuvant chemotherapy and then did a pneumonectomy to get rid of this tumor in a bad location. And this is what came across my desk. So here's the pulmonary artery is there on the bottom of the image, the wall of the pulmonary artery, and you can see this intraluminal tumor, spindle, you can see this chronic inflammatory infiltrate accompanying it. They had some sort of pseudoangiomatous blood-filled spaces within the tumor. And you can see here the tumor was actually invading through the wall of the pulmonary artery into the adjacent soft tissue. And it had this dense lymphoplasmacytic cuff surrounding it. And when you come down on higher power, the tumor is clearly spindled, but actually relatively monotonous and had, in some areas, intermixed lymphoplasmacytic and plasma cell-rich infiltrate, although most of it wasn't particularly inflamed. Most of it sort of looked like this. And this is the one mitotic figure that I could find. This had almost no demonstrable mitotic activity in the tumor. And then in some areas it had a prominent myxoid stromal background that seemed to vary from area to area. And this is the immunoprofile. I failed to photograph all of these various immunostains, so you just have to look at this table really quickly to see what a confusing immunophenotype this is. Lots of negative stains, but there was focal positive OSCAR and EMA, a little bit of CAM-FLAG.2 in one little area, focal weak SOX10 and S100, focal weak calponin, and focal CD31. Desmond negative, melanocytic other melanocytic markers negative, sympathism negative, P40 negative, STAT6 negative, so kind of ruling out a whole lot of things here. So I'd ask you, if this came across your desk, what would you call this? Is this a myeloepithelioma with a little bit of keratin, SOX10, S100? Is this a hyalinizing clear cell carcinoma, primary pulmonary myxoid sarcoma, so-called, or maybe extraskeletal myxoid chondrosarcoma or angiomatoid FH, or maybe you'd call this an intimal sarcoma anyway, maybe MDM2 non-amplified. I suppose that's not a terrible idea, or maybe you have no idea at all. So these are the things that sort of ran through my head when I had this case. And I like to, when I get cases like this that are confusing, I like to go back to basics and think, what is my diagnostic algorithm here? And this is my approach to spindle cell neoplasms in the chest. This is what I teach our fellows, our trainees. First of all, is the tumor pleomorphic? Because if it's pleomorphic and obviously malignant, then it will send you down a certain diagnostic pathway where you're really considering sarcomatoid carcinoma, maybe sarcomatoid mesothelioma in an appropriate context, or melanoma and other high-grade bad pleomorphic things. But if it's not pleomorphic, and it's not obviously malignant and probably synovial sarcoma, then you're sort of left with this as your diagnostic approach. And this is where it gets interesting, of course, because tumors that are monotonous and not obviously malignant tend to include those interesting things to the soft tissue pathologist with translocations and other interesting molecular abnormalities that we get so excited about. And these are the bland spindle cell neoplasms that occur in the lung generally, and the ones that I think of when I encounter a case like the one I started out the talk with. Carcinoid tumors, of course, are common. They can be quite spindled, and most of us are really comfortable with carcinoid tumors or well-differentiated neuroendocrine tumors in the lung. We can easily diagnose them with neuroendocrine markers and the right kinds of stains. And then, of course, there's all of these other things that I'll go through. So the solitary fibrous tumor, most of us are comfortable with as well. It's relatively common, and of course, most of them are pretty easy to diagnose as long as you think about it and order your STAT6 and CD34. That's STAT6, of course, being overexpressed because of the presence of that characteristic fusion. The only real challenge, I think, with solitary fibrous tumor is when you get CD34 negative examples. They can be kind of tricky. Inflammatory myofibroblastic tumors, of course, these are true neoplasms, they're not pseudotumors. Many of these will have characteristic molecular abnormalities you can identify, particularly in a small biopsy. They typically have these plump myofibroblasts with prominent chronic inflammatory infiltrates, and many will be ALK positive. And these certainly are the types of tumors that might come into the differential in a case like the one I've shared with you. Pulmonary hamartoma you have to include in the differential for any kind of low-grade spindle mesenchymal neoplasm in the chest. But these, of course, should have multiple mature mesenchymal elements in them. Mature myxoid mesenchymal tissue, mature fat, mature muscle, bone even, typically with entrapped or invaginated respiratory elements. Benign peripheral nerve sheath tumors, of course, can occur in the lung, typically in an endobronchial and peribronchial location. Most of the time I see them, they come in labeled as a lung tumor, but in fact they're a chest wall pleural-based tumor that's misinterpreted on radiology as a lung tumor. But they look like peripheral nerve sheath tumors anywhere. Schwannomas, neurofibromas, and have characteristic immunophenotype. And as long as you recognize them as being of peripheral nerve sheath nature, the diagnosis is relatively straightforward. Then, of course, there's the alveolar adenoma, which is quite rare in clinical practice. It's always this very rounded, well-circumscribed lesion in the periphery of the lung with these characteristic cystic spaces with a bland CD34 positive interstitial population of interstitial spindle cells. And then we come around to this entity, which was first recognized in 2011 by Cyril Fisher, Kenneth Way, and their colleagues. They coined the term primary pulmonary myxoid sarcoma for the distinctive low-grade myxoid spindle cell neoplasm in the lung with this characteristic fusion, EWSR1 CREB1. Which was described as a circumscribed, typically endobronchial mass, often identified incidentally in younger adults with these sort of low-grade spindle distellate cells in a myxoid stromal background, mild atypia at best, low mitotic activity, and these are typically indolent and only rarely metastasizing tumors, and most of them have this gene fusion event. Well, it didn't take long till the same group recognized that angiomatoid fibrous histiocytoma can also occur in the lung, which happens to have an identical gene fusion associated with it. And we know from the soft tissue pathology literature that these angiomatoid fibrous histiocytomas, they have many features that overlap with primary pulmonary myxoid sarcomas because they can be quite myxoid, and they can occur in the lung, usually in the same location, in a sort of bronchial, peribronchial location. But they often have a pronounced lymphoplasmacytic rim. Sometimes they have blood lakes or pseudoangiomatous spaces, but not always. And tend to behave in a fashion that's very similar to a primary pulmonary myxoid sarcoma. They're low grade, they're indolent, sort of local recurrence problems, but not generally, metastatic problem. And it was proposed by numerous groups when these overlapping features were recognized that these two entities are probably related to each other or maybe falling on a morphologic spectrum. So coming back to the case I shared with you, what in the world is this, or what did I think this tumor was arising in the pulmonary artery? Well, we started out by doing molecular testing and did FISH first, and it was positive for an EWSR1 gene rearrangement. We think, well, that's great, are we done? But I just offer you a little bit of word of caution. Of course, EWSR1 gene rearrangements are seen in a lot of different tumor types, including all of these that can occur in the lung. And so it's not really, I think, enough here to just recognize that an EWSR gene rearrangement is present because of all these different diagnostic possibilities. So you think, well, maybe next-gen sequencing will help us here better than FISH, and we did next-gen sequencing and it identified EWSR1 CREB1, which I thought, well, great, that's fantastic. And then remembered that there's a big list of tumors that have EWSR1 CREB1 translocations, and I've got 6 of them here, and it's probably an incomplete list. And at least 3 of these occur in the lung also. So again, not pathognomonic of any specific entity, this exact fusion. So interpretation of the molecular findings in this case really has to be done in combination with the clinical findings, the imaging findings, the morphology, the immunophenotype, bringing everything together, which I think in this case, this fits best for a diagnosis of angiomatous fibrocystoma, the so-called myxoid variant with this particular gene fusion. Although I suppose others could argue with me that this is a primary pulmonary myxoid sarcoma arising in an odd location in the pulmonary artery. So who knows? We don't have perfect guidance on this subject yet from the WHO. The WHO acknowledges that we don't really understand the relationship between these two tumors. It's not entirely clear. The WHO book states that there's supposed to be reticular morphology in primary pulmonary myxoid sarcoma and lack of desmond expression that could theoretically be helpful to distinguish them, but in our experience that's not the case. And we, with some of my colleagues at Mayo, we published this last year comparing 16 cases of primary pulmonary myxoid sarcoma and angiomatoid FH in the lung and saw completely overlapping morphology between the two, overlapping immunophenotype, and they really do seem to be the same entity, and it's probably doesn't make a whole lot of sense to divide them into 2 different diagnostic terms, which should probably retire primary pulmonary myxoid sarcoma and call these for what they really are. They're angiomatoid fibrocystoma arising in the lung. But one thing that we did see in our series that was interesting is expression of ALK and or synaptophysin in a good number of cases. About a third of the cases in the study had expression of one or more of those, or both of those markers. And when you think about a tumor arising in an endobronchial location where inflammatory myofibroblastic tumor is going to be an important consideration, and of course carcinoid tumors arising in that location, this is a diagnostic pitfall. Thankfully, all of the tumors in our series were negative for chromogranin. So, just a couple final thoughts from my first case here. When you're dealing with a low-grade spindle cell tumor in the lung, remember, if it's not a carcinoid tumor, it's probably a mesenchymal tumor, so molecular testing can be exceedingly helpful. Although don't be confused by it, you've got to interpret molecular information in the broader clinical, radiologic, and morphologic context. So with that, appreciate your attention for case 1. I'd be happy to answer any questions anybody has.
Thank you very much. Any comments, questions? David?
Yeah.
Can you lead this one or you?
I just scream. Brandon, in your study, how many cases had actual angiomatoid growth?
That's a great question. I have to go back and look at the table. I forget, not all of them have obvious angiomatoid sort of blood lakes or pseudoangiomatoid growth.
Yeah, that's like, I have like 6 of these on my desk right now, and none of them have like blood lakes, which is weird because in the soft tissue, that's like how I identify. When I get a solid one, it always throws me off. And the blood lakes, like I keep seeing these getting presented and reading the studies that come out, and like all the images look like they're solid myxoid things. So they're kind of funny.
Yeah, I don't know if it's because they're arising in the lung, they end up with sort of different alterations from a morphology standpoint. You know, the soft tissue thing I was always taught was they look like, you know, lymph node metastasis that's gotten bloody on the inside. And in my experience, when I see them in the lung, they don't usually look like that. The lymphoplasmacytic rim may be less pronounced or more indistinct and not always with blood lakes.
Short question. How do you rule out the metastasis?
Great question. Clinical history is everything, right? So, you know, this case, it was clinically presumed to be either intimal sarcoma or metastatic, and the patient had had a full staging workup before they took the patient to surgery and had no evidence of disease anywhere else. So I think it's probably the best and most reliable way to make that distinction.
I agree. It's just. Okay, thanks. Please go ahead with your next.
All right, thanks. Okay, last case before lunch. Okay, shifting gears a little bit. Case 34, this is a 42-year-old man with cystic lung disease. So I'm a thoracic pathologist. I love non-neoplastic lung disease. So you had to get a little flavor of it from me today with a cystic lung disease flavor today. So this patient actually presented with diffuse cystic lung disease with cysts that had been enlarging. He was a never smoker and he had no other chronic medical problems. These are images that I got from the clinician, and these are, you gotta be careful here because 2020 is on the right and last year's on the left. So before and after backwards. But you can see here, if you look carefully as I scroll through these, there's scattered cystic lesions in the lung. I don't know how to use the mouse on this thing. How do I make that fancy? Press and hold. Let's see. Oh, that's fantastic. Everybody else is doing this. Is fun. It makes you feel in control. So, you know, not very obvious cysts here. You go over to 2024 and you can see, you know, these thin-walled cysts. And if you look really carefully, some of them actually have what appear to be small mural nodules in them that have developed in the last 4 years. Here's a really nice one up here at the top, and if you go 4 years prior, it's really not there. So these cysts were increasing in size, increasing in number, and increasing in mural nodularity. And this is wedge biopsies that were eventually obtained to figure out what this guy's cystic lung disease was. You can see here there's several collapsed cystic structures here underneath the pleura in these wedge biopsies. You come in a little closer and you can see this spindle cell proliferation associated with this collapsed cystic structure, multiloculated cystic structure. Here we see the cyst wall with kind of bland spindled cells in it. And then there was another lesion that was removed that was more nodular in appearance. Here's the nodule, and you can kind of get a sense that this is also associated with early cystic parenchymal change. Here, when we come into higher power, you can see that how this thing looks. There's foamy histiocytes within the lesion. It has a little bit of a storiform, vaguely fascicular growth pattern. So if this came to you, what would you be thinking about diagnostically? And, you know, I've listed a bunch of cystic lung problems here on the list. So the first thing you might wonder about is lymphangioliomyomatosis, because none of these are particularly common, but that's a relatively common form of cystic lung disease, and pulmonary lung or hot cell histiocytosis. Maybe benign metastasizing leiomyoma, although this is a man and not a woman with a uterus. or metastatic low-grade endometrial stromal sarcoma, metastatic dermatofibroma, or maybe you have no idea. So I want to talk briefly about diffuse cystic lung disease. And how do I approach diffuse cystic lung disease? What's in the differential? And it's important to go back and remember what kind of disorders can lead to diffuse cystic parenchymal abnormalities in the lungs. And there are non-neoplastic and neoplastic causes. When we think about non-neoplastic causes of lung cysts, probably the most common is going to be emphysema, or at least something in the differential diagnosis. Emphysema I don't think of as a cystic lung disease, but it has, thin-walled, large air-filled spaces that can be confused with cysts, and occasionally you can get cysts in smokers as well. And then there's, of course, so-called lymphoid interstitial pneumonia. That pattern is, at least to our clinical colleagues, thought of as a diffuse cystic lung disease associated with certain conditions. And then there are genetic forms of non-neoplastic diffuse cystic lung disease, Burke-Huntley-Bay syndrome, of course. Folks with Down syndrome can end up with lung cysts and a variety of other genetic disorders that are fortunately relatively rare. And then we have neoplastic causes of diffuse cystic lung disease, and probably the most common one that we encounter in clinical practice is actually pulmonary Langerhans cell histiocytosis in cigarette smokers. But then there are less common causes of diffuse cystic lung disease like amyloidosis or light chain deposition disease associated with lymphoma, and then cystic metastases. When we look at the relative frequency of these in clinical practice, these are the ones that we see most often. And the rest of these are pretty rare, and we don't think of them that often. And when we think about cystic metastasis, most of us remember lymphangioliomyomatosis, or LAM, but it's important to remember that there are a variety of other low-grade spindle mesenchymal neoplasms that, when metastatic to the lungs, will result in this cystic parenchymal change, which is interesting, like endometrial stromal sarcoma, benign metastasizing leiomyoma, DFSP, etc. So I'll just illustrate some of these with a couple of cases. So this case was a 21-year-old woman with lupus and diffuse cystic lung disease who had progressive dyspnea. Her CT scan had bilateral granulosal opacities and numerous cysts of varying sizes in both lungs. They did a wedge biopsy. You can see here the cystic parenchymal changes here at low power. They're pretty obvious. When we come up a little bit on higher power, you can see the lymphoplasmacytic infiltrate, relatively dense, that's associated with this cystic change in the walls of the cysts. And dense enough that in some cases you might even start wondering about a malt lymphoma. If you work this up for lymphoma, this would be consistent with a benign reactive process. And this is, of course, something that I would call lymphoid interstitial pneumonia pattern in a patient with cystic lung disease. And this disorder is really a pattern, but thought of somewhat differently by pathologists and our clinical colleagues. In radiology, this is a cystic lung disease, but in pathology, we teach that this is a diffuse chronic inflammatory disease, and that in fact is true, but generally the inflammatory patterns seen in lymphoid interstitial pneumonia are varied and not, like what we traditionally have taught with, a cellular NSIP that's more diffuse and dense, where you're worried about lymphoma. That's the classical training, but really in pathology, what we see with lymphoid interstitial pneumonia is a mixture of inflammatory patterns. It can be follicular bronchiolitis, diffuse lymphoid hyperplasia, or micronodular lymphoid hyperplasia, but usually not cysts. So this case I've shown you is actually somewhat unusual because we do have nice cysts that are identifiable on pathology. And lymphoid interstitial pneumonia is almost never idiopathic. When it's properly worked up, it's most of the time associated with rheumatologic disorders, occasionally with immunodeficiency disorders, and once in a while as a manifestation of a drug reaction. Second cystic case I'll show you is, this is a quite typical case, 71-year-old woman and heavy smoker with upper lobe predominant cysts and nodules. Or you get a lung biopsy, you can see here there's a cyst, and if you look carefully, there's a couple of small cysts in these wedge biopsies. When you come on higher power, you can see the sort of stellate fibrotic alteration accompanying these cysts. If you look more closely, there are pigment-laden macrophages, but probably also some non-pigment-laden macrophages in there that are relatively subtle, but if you get your stains for Langerhans cell, CD1A, which in this case is a red chromogen, you'll see increased numbers. And if you have the stain available in your lab for BRAF V600E, if it's positive, it can help because about half of these cases actually have that mutation. That's of course pulmonary Langerhans cell histiocytosis, and you can even get these on a core needle biopsy in an individual with a larger size nodule. They may occasionally put a core biopsy into that lesion where you can see a more cellular process with admixed eosinophils and abnormal histiocytes, and your CD1A will show a lot more cellularity. On which biopsy you might end up with lesions that are a little less obvious, but still on the cellular side. Here's the CD1A in this case, this peribronchial nodular expansion of Langerhans cells. And then they can be less cellular, of course, as they go into the fibrotic phase, but still with a few residual Langerhans cells. So remember, Langerhans cell histiocytosis, the pulmonary form, is almost always associated with smoking. It's an upper lobe predominant disease, just like any smoking-related process, with nodules that can evolve over time from more cellular nodules to stellate fibrotic nodules that then are accompanied by cyst formation. The treatment, of course, is smoking cessation, but if systemic therapy is desired, a BRAF mutated form of the disease could potentially be targeted with that vemurafenib or BRAF targeted therapy. Case C, this is another case, 38-year-old woman with cystic lung disease and prior smoker with a normal VEGF-D serum level. And VEGF, of course, is elevated in many patients with lymphangiolymphomatosis, and so a young woman with cystic lung disease who's presumed to have LAM many times will have that VEGF-D level done before the biopsy ever comes to you. But in this particular case, it was normal. And here's her imaging. You can see, if you look carefully, holes in her lung, cysts, thin-walled cysts bilaterally. There's some more. And then a wedge biopsy was done. And here we can see some cysts. There are some more cysts, easily identifiable at low power. And when you go hunting around, you see, in fact, there are spindle cells in the walls of those cysts. And at closer look, they do have a myeloid appearance. And of course, this should prompt you to work up for LAM anyway, even though the serum VEGF-D level was normal. And this case did have SMA immunoreactivity in those lesions. And this is the type of case that gives people problems because the HMB45 here is positive, but it's only focally positive. If you look really carefully, there are scattered individual cells in those nodular pericystic collections of neoplastic myeloid cells that have expression of melanocytic markers. So if you're not careful, you'll blow all this off as negative, it can't be LAM, but in fact this is, in my experience, characteristic of LAM in some cases to have very minimal melanocytic marker expression, which is a diagnostic makes it a challenge. This case did have ER expression, some weak MITF expression, and cytoplasmic beta-catenin, which is often also present in LAM. So this is a case of LAM, I believe. And LAM, we all know what LAM is, a member of the Pacoma family with a peculiar dual myeloid and melanocytic immunophenotype, almost always in women of childbearing age, probably arises in the gynecologic tract. And can be spontaneous or associated with tuberous sclerosis. And the characteristic clinical presentation in most cases is cystic lung disease with diffuse cystic lung metastasis. Again, low-grade spindle cell mesenchymal neoplasm ends up metastasizing to the lungs and producing that peculiar diffuse cystic alteration. Sometimes this disease also is accompanied by micronodular rhingocyte hyperplasia with little lung nodules. Challenges, I've already mentioned that LAM can have minimal staining with melanocytic markers, so I will often get all the melanocytic markers available to me in my laboratory. HMB45, MELAN-A, or MART1, MITF, do them all because you want to find that focal melanocytic marker expression. And many times you have to hunt for the LAM cells. In a patient that has a low LAM burden, they can be difficult to identify in a biopsy unless you've thoroughly sampled the specimen. I will often submit the entire specimen to look for very subtle foci of LAM cells with those cysts. This case was another case of cystic lung disease in a woman with no history of smoking. She had innumerable lung nodules and cysts. And here's one of the cysts that was removed. You can see this low-grade spindle cell proliferation with this. And here are the immunostains, strong ER positivity, strong diffuse desmin, negative melanocytic marker expression, and negative CD10. So in a case like this, in a woman, the things I would typically be wondering about, metastatic endometrial stromal sarcoma, but the CD10 is negative. And what this is, benign metastasizing leiomyoma, so-called. And she, looking back in her history, she had actually had a hysterectomy for leiomyomas about 5 years prior. And then here we are back to our case. So what in the world is this sort of fibrohistocytic looking tumor with cystic parenchymal alterations? Additional clinical history on this patient. 12 years ago, this patient had had a benign skin lesion excised. No further details were available, but I did learn that 8 years prior, he had an episode of hemoptysis while he was running. He saw his primary care physician, was lost to follow-up, and then 4 years ago presented with a spontaneous pneumothorax where they identified bilateral cysts on the CT scan. So pneumothorax as a consequence of cystic lung disease. And here's the immunostains in this case. Some CD163 expression, some factor 13A expression, negative SMA, a little bit of SMA, negative CD34, and lots of other IHC studies that were negative. You can see the list there. Melanocytic markers, other histiocytic or monomer type markers. And we did send for next-gen sequencing in this case, and this did come back with a PRKCD protein kinase C fusion, which are characteristically seen in dermatofibromas or cellular fibrous leukocytomas. So I believe this is a case of metastatic dermatofibroma with this gene fusion, which is pretty uncommon, but kind of interesting to see one of these every 5 or 6 years. And often clinically, ignored the fact that they had this large benign skin lesion removed and now it's metastatic. So final thoughts, diffuse cystic lung disease, remember cystic metastasis, and remember cystic metastasis beyond just LAM. Clinical history is often lacking, particularly in consult material. Again, remember other low-grade spindle mesenchymal neoplasms can metastasize to the lungs and cause diffuse cystic lung disease, endometrial stromal sarcoma, benign metastasizing leiomyoma or low-grade liposarcoma, dermatofibroma, DFSP, and a variety of others have been described as well. So I'll leave you with that. Happy to take any quick questions or we can go to lunch.
Thank you very much. Quick comment or question? Everyone?
Great presentation, Brandon. Have you tried to do cathepsin K in those cases of lymphangiomatosis where the melanocytic markers are just staining rare cells?
That's a great question. It's the one marker that we don't have in our local laboratory yet. We're actually validating it right now. I'd love to give that a try. I don't know if you've done that in your cases.
In GYN we do it, and whenever we are having problems with the melanocytic markers, cathepsin K works quite well.
Thanks for your comment.
Okay, so thank you again for a very excellent presentation, and now we will take the lunch break.